friends, peers, everyone that's gathered here today, a very warm welcome to each one and every one of you. Uh, Today we have an interesting seminar which is planned. The theme of that seminar is exploring missing links in nutritional management of chronic diseases. It's an immensely mm, relevant and thought provoking topic which needs to be addressed in multiple as much detail as possible and in as many forums as possible. Today I'm very sure that we are going to have an excellent exchange of ideas, and it's going to be a thought provoking session because we have an excellent lineup of speakers and panelists, and so you're going to get a great discussion forward. So just let's begin this journey without wasting a lot of time. To take this program forward, I would like to introduce a very young, smart dietitian. Well, to me young, because it gives me great pleasure to introduce Shalini, who is a very talented and skilled dietitian whose expertise and passion are matched hand in hand. So she is a 1 minute. Sorry, can you all see? Yeah. Both sides, okay. She's a postgraduate in food science and nutrition from Mysore University. She's a registered dietitian and a certified diabetes educator with 20 years of experience. She is currently with the chief dietitian and head of department of dietetics at Fortis Hospital, Bangalore, at Bannerghatta Road. She's carried out research at CFTRI and Fortis Hospital as well. Her papers have got published at Oil Technologists Association of India and Endocrine Practice. She's certified in ketogenic therapies in epilepsy and cancer. One very surprising thing, with diverse interests in the field of nutrition, she's also done a certificate course in sports nutrition, which is quite a surprise for clinical dietitians to do so. Yeah. So she has mentored many PhD and many RD and non-RD students. She's co-authored 2 books, Nutritional Secrets and Heartbeat, the Attack the Heart Attack. Frequently writes for print media and clinical journals, and has given many sessions on social media as well as televisions. She has been a speaker and a panel member in various nutrition forums, and she's also given a lot of lectures at corporate offices, manufacturing industries, and schools. She served as the IDA Bangalore chapter secretary in the past. Currently, she's the co-convener of IDA Bangalore chapter, and she's also the executive member of IAPN India Bangalore chapter. She is the head of department of dietetics at Bannerghatta, which I already mentioned. So I will ask her to take the program forward, and please welcome her on the dais with a very big round of applause. Yeah.
Thank you so much, ma'am. Good afternoon to everyone. Small crowd, small family, happy family. I think that's what we have to feel today. Okay. Good afternoon, everyone. I welcome everyone, all my seniors, peer groups, and juniors, and it's a happy setting to have you all here. First of all, thanks to Anjana ma'am, Wello'Tree, Dr. Rihan, Arjun, and Wello'Tree for associating with IAPN Bangalore chapter and also giving me a chance to participate in this. I'm not going to take much time. We'll straight away jump to the session. And no question is big, no question is small. So please write down whatever you feel like asking. We should all learn from each other. There's always a place where we have not explored. So it's a chance that we can learn from each other, right? So first I would want to call upon our first speaker. She is such a rich personality with her resume. It's so inspiring to even read about her resume. So we have Dr. Shripriya Mahesh, and she holds a PhD in nutrition services from Rutgers University. It's in New Jersey, one of the leading research institute, and she has done her PhD from there. She spent 6 years doing that. And her thesis topic was molecular aspects of targeting estrogen receptors in breast cancer. She did her BSc in nutrition and masters in sports and nutrition, exercise nutrition from Nirmala Niketan, Mumbai. She did PG diploma in clinical nutrition and dietetics from IHMCTA, and that is Institute of Hotel Management, Catering Technology, and Applied Nutrition. I did my homework, Mumbai, right? And her expertise in physiological, molecular, and genomic aspects of nutrition. She is a content creator and also LMS architect. That's learning, I think managing system. And she also heads the content writing for Cuddles Foundation. It's very inspiring to know from her the work they are doing. It's basically an organization which works for pediatric oncology patients, right? And she is an advisor for many nutrition startups, and she herself has been a speaker at TED Talks. Would really love to go and listen to that. She has done. She has contributed. Sorry, I'm audible, right? She has contributed her. I think it's. Yeah. Yeah. Okay. So she has contributed to IAPN India with the paper on consensus guidelines and recommendations on nutritional management of pediatric cancer patients in Journal of Nutrition Research. And she has also contributed in nutrition pediatric palliative care in the textbook of pediatric palliative care. She is a member of International Society of Pediatric Oncology, Indian Pediatric Hematology Oncology Group, and also IAPN India and IDA. She is an associate treasurer in Association of Sports Nutrition and Fitness Science. It is such an honor to have you, Dr. Shripriya. We would love to learn from you. Please do come over. I'll go back. Where is your slide? It's another file, ma'am.
Thank you so much. Thank you so much, and for this warm welcome, Shalini. And thank you so much for doing the homework also, because I realized when I was looking at it, there were too many acronyms in that introductory slide. But thank you so much, and thank you so much, Anjana ma'am, Dr. Rehan, Wello'Tree, Sunita from IAP in Bangalore, who gave me this opportunity. And it's really nice to see the audience out here. And I'll try to do my best in sharing some missing pieces, in oncology that we see, and because that's the overarching theme today. So that's for my entire presentation is focused on. It's not. It's not moving. It's not moving. No, it's not moving here. I don't see it here. Is someone else controlling it? Because I don't see it moving here. Let's do this. This up and see. Why is this a problem listening?
Where is this PPT? It's in desktop.
Yeah.
Shall I close this thing? This is the PPT?
Yeah. Yeah. Thank you so much. Thank you. All right. So in this, these are some fundamental questions I always ask when we think about nutrition, right? Why do we do something? Why do we need to do something? How do we do it? And what else can we do it? And that is pretty much the structure of this 25-minute presentation. So before we go on, right, I just want you all to have a look at it, take screenshots if you need. But I would like you to bring focus into two important papers, I feel, and that we have from the IAPN's table. And the important part why I wanted to bring this up in the beginning of this was because my focus is on proteins. It's going to be very one-sided, or rather not even one-sided, but really, really just a small piece of the puzzle. Whereas these two papers that I'm going to showcase here is going to give you the entire picture. So this paper does not just talk about protein, but it talks about carbohydrates. It talks about every aspect of adult oncology. The first paper. This was a paper that came out in 2021, and it had a lot of oncologists and nutritionists across India collaborating. And this was the first paper on the consensus guidelines on adult oncology. This is the next one. This is a screenshot from my desktop, and this is a paper that's in press. Still addressing some reviewers' comment, but hopefully in the next couple of months, it should come out again in the Journal of Nutrition Research. And this particular paper, where we tried to put in consensus guidelines for pediatric oncology. It was very challenging because if you see, like, the percentage of pediatric oncology cases in India is very, very less. And that's the truth across the globe. And as a result of which, not much of research or recommendations or guidelines actually come out in the pediatric oncology domain. So why really? So the first question, right? Why? So some cancer statistics. So if you look at it, and when you look at a cancer, whenever we see a cancer patient, right, you have to look at three things. First is, are we looking at an adult patient? Are we looking at a pediatric patient? And some of it is also a survivor. How many of you actually see survivors here? Do you have ACT clinics? No, but you do look at survivors. Okay. So, so you are having these three demographics within the entire oncology realm. And if you look at the number of adult oncology patients, it's increasing day by day. And the awareness is also increasing, latest because of the Kate Middleton, diagnosis and King Charles diagnosis. You see there is an increased number of awareness, and as a result, or I don't know if that is a result, but there is an increased number of adult diagnosis also happening. So recent estimates puts it around 1.4 million, that's about 10 lakhs, 10.4 lakhs. Whereas if you look at the pediatric segment, that's about 75,000. That's what we think will be diagnosed with cancer. Much less, we see much less a number of patients because a huge number of kids go undiagnosed. Now, survivors, on the other hand, if you look at it, the first two statistics are given as per year, but the last one is given as an absolute number because we really don't have data on this. So as per the recent estimate, which I got of the NCG, is about, we have about 21 lakh survivors. Now, when you're talking about survivors, I will not be going into the protein requirement or specifically into this, because these survivors are considered as normal, and the protein requirements or the modifications that you need to do would pertain primarily to the late effects that you see. The late effects are your obesity, your hypertriglyceridemia or diabetes that you see, or hypertension that you actually see once, 10, 15 years after a successful treatment. So we won't be really looking at that, but let's, going back to the first one, which is your adult oncology cases. The top 5 is your stomach cancer, breast cancer, your anything to do with the oral cavity, and lung cancer. And you see these are all lifestyle related, right? And the top cancers in pediatrics is primarily your leukemias. Now, however, with both the set of population, we see a lot of malnutrition happening. We see about, depending on the site of diagnosis, site of cancer, and depending on the type of treatment that they undergo, and the time that it's taken for them to come from the first sign or symptom of cancer to the actual diagnosis, right? It's a huge, sometimes it actually can, in children I've seen it, sometimes it takes about 8 months or 10 months, especially in the low economic strata, because some of these symptoms of this is like bone pain and things like that. Typically parents think, Arey, you know, it's just growth pain, it should be okay. And sometimes even the primary care physician sometimes misses this. So given, because of that, sometimes there is already, you know, a malnutrition setting in till they come for diagnosis. So it ranges is between 10 to 80% in 20 to 80% in adults, whereas in children it could be around 20 to 80%. And this is a reason why we really need to look at protein. So what we were discussing primarily is malnutrition, right? And we see in cancer patients loss of muscle mass, loss of weight, and depending on the type of cancer and the treatment that they undergo, there could be either a lowering of the body fat or an increase in body fat. Okay. Now, if you look at this altered body composition that we see in cancer patients, it could be because of aging, right? Aging, you have something called as sarcopenia, which is again a type of loss of muscle mass, but not to be confused with cachexia, right? Sarcopenia is wherein there is an atrophy of the muscle cell or muscle mass, whereas in cachexia is basically wherein there is a loss, and within the muscle fiber they see that there is an increase in the fast twitch muscles or the glycolytic muscles, and that is the reason why they have a lot of fatigue, because it requires a lot of energy. But I'm digressing, so let me just come back here. And cachexia is the primary cause of cachexia is inflammation that's happening because of the cancer changes, the microenvironment changes that happens. And inflammation, like we all heard about this, you know, when COVID happened, we heard about all this, different types of inflammation that's happening. And increasingly, even with oncology, it's been considered as a inflammatory disease. And a lot of adjuvant, like, or alternate treatments, parallel that's being under clinical trials is how to douse the inflammation fire. You know, that's the way they are trying to approach oncology. So inflammation is one of the primary causes of cachexia, and in aged adult oncologic patients, you have sarcopenia meeting cachexia, and that's where you really have, quite a bit of challenge. You also have hormonal disturbances, which could be, it could be related to gynecological changes that happen, gynecological tumors that happens, or it could be because of the treatment. For example, certain types of cancers like leukemia, they have steroids as part of the modality, right? So in those cases, you see that there is an increase in the body fat. And you normally think, okay, they are fine because they're actually increasing in weight. But you realize if you go a little bit more deeper, it's not really increase in muscle mass, but it's increase in body fat, which is again not a great thing. You also have altered energy metabolism. It's in hypercatabolic stage, especially in the initial phases when the especially solid tumors are extremely active, and where probably induction has not started, or the initial treatment to decrease the load of cancer cells have not happened. There is a huge requirement of energy, and combined with it, you have food intolerances, or even like reduction in food intake because of anorexia and nausea, vomiting. So it's all coming. It's like a disaster looming in, where the body is asking for more nutrients, but the body, you're not able to supply it. At the same time, multiple things are happening. And one other thing which myself and Sunita were discussing it. You cannot compartmentalize physical activity and nutrition. You know, they have to go hand in hand. And physical inactivity, I mean, as we all know, we're all seen, right? If the moment the patient is inactive for a period of time, he needs physical rehabilitation, because that's, you know, you have an atrophy of the muscle cells happening. So a lot of time you see cancer patients being physically inactive, and all of this results in reduction in muscle mass, and as a result of which you have frailty. Like, you see patients not able to walk, being able to walk. Even after you correct for vitamins and minerals, electrolyte balance, they're still not able to walk. There is a reduction in quality of life. You will see that chemotherapy dosages sometimes need to be stopped. In pediatric cancers, I see a lot of times the parents decide that they don't want to continue the child on treatment. They'll abandon the treatment because the child is unable to walk, and then they would go for the alternative modes like Ayurveda or whatever, which they think would be okay. And there is also a stoppage of sometimes chemo, wherein there is tremendous weight loss, and then we'll say, okay, let's do it. So typically, if you look at chemotherapy dosages, they usually do a BSA, body surface area measurements. That's the way they calculate your dosage. And of course, in about the last but not least, there can also be death. There was a Western reference that I came across, and that was actually very, for me, very profound, where they said that 20 to 40% of death, okay, due to cancers is not because of the tumor, but it is because of the malnourishment. So for me, that was a very, very profound statement, and it also gives a lot of importance. It shines a light on the importance of nutrition in oncology. So when we looked at malnutrition, so I was talking all about malnutrition, right? And how do we, any students, anyone who wants to volunteer, like, what was the malnutrition definition till now? What did we define as malnourished? Anyone in the audience? Sorry? Lack of nutrients. Correct? Then? Sorry? Excess of nutrition. Or insufficient nutrition. Yes. Correct. So you also would actually categorize, sorry? What? Low lean body mass, yes. So basically, if you look at the WHO anthropometry, like your charts and everything, they're all related to like height for age, height for weight, BMI for age. All parameters of height and weight is what is actually considered for categorizing of malnutrition. But for me, this is very exciting. This particular definition, which came out in 2019, was very exciting because it took into account the functional aspect of a patient. And for me, this is extremely important because even if you have a child or if you have an adult of the right BMI, according to conventional nutrition, you would categorize them as probably nourished. It could be because there is an increase in body fat or whatever, for whatever reasons, right? But the functional aspect of this patient is not there. And what is, the whole point of having nutrition support is to address the quality of life. So for me, this malnutrition definition is very nice because it also takes into account the functional aspects of it. And they clearly say that these functional aspects, the cutoffs, they don't have a clear cutoff, but then they say it is according to either a DEXA or a BIA or one other parameter that I will show in the next slide. If anyone's interested in more, please look at the reference that I've given in the bottom. GLIM categorizes on patients in two categories. That's the moderate malnutrition and the severe malnutrition. The severe malnutrition, you can find it from the reference. Who knows what this is? No. Cheating. Let's have any of the interns or the students coming up. Anyone on what this is? Hand grip? Yes, that's correct. What is it called? It's used to measure hand grip. What is it called? Correct. It's a dynamometer that you see on the right side. On the left side of the screen is an analog version, which shows how the hand grip analysis is done. And you have a digital version. So typically what you do is, so what you typically do is you hold on to the You typically hold on each side 3 times. You actually have to squeeze, and then you take an average of it, and that's the measurement. And you have parameters, you have cutoffs for adults that shows the strength, the hand grip. And hand grip is one of the parameters that they actually allow in the GLIM. They mention about it in the GLIM definition. Hand grip is actually really coming into the picture in the Western countries because they're using it not just to measure, undernutrition very subjectively, apart from your BMI and weight. It's an add-on to it. It can also be used beautifully to check how effective your nutrition intervention is. So you can tweak your nutrition intervention. If you're doing a longitudinal measurement of the patient, you can actually see whether your nutrition intervention is working or not. So this is, I think, one missing piece that I would really wanted to talk about today. The next question is, how much protein do we give? So I've taken Indian references, but again, the challenges with most Indian references is we take guidance from SPEN and the other Western organizations. The adult measurements, if you look at adult recommendations, is about 1.2 to 1.5 grams per kg per day. Again, this is a very, very broad requirement and a recommendation, and it would change depending on the side effect or specific clinical condition, or even say, for example, if there is a renal involvement, you will actually need to titrate the recommendation dose. This is from the IAPN 2021 consensus paper. For pediatrics, we really don't have a recommendation, though we have mentioned in our consensus guidance that you follow NIN, but which is about 1 gram per kg body weight. But on the field, in practical, we do see that a child might require 1.5 to 2.5 grams per kg body weight per day. So all this becomes moot. Your recommendations, your diet plannings all become moot the moment you see what are the barriers, or you understand the barriers for either the protein consumption or even the absorption of protein. So there was one research article that I saw in the Western, I think it was from the US, that said that about 65% of adult oncology patients do not meet their protein requirements, even though a dietitian is actually working with them. So the functional challenges of protein, intake is always there. But for this, I just kind of categorized into 3 different, which is where you have your gastrointestinal dysfunctions. So any carcinomas that involve the GI tract, of the colon, of the esophagus, or any one that actually impacts either absorption in terms of secretion of enzymes, or like they could be mucositis, or they could be like obstruction. It would impact food intake, and as a result of it, it would impact the overall protein consumption. The second thing is, of course, fatigue. That's something which goes hand in hand in oncology patients. They're just too tired to eat. They don't want to eat. Along with it, add to it depression or any of these other social issues will also impact food intake. Anorexia, taste changes, goes hand in hand with chemotherapy. And that's another issue which we always have to consider when we are recommending protein, because a lot of time protein foods can be bland, or they don't like the taste of it or the smell of it, and that becomes a huge challenge. One other thing which I've experienced this in my private practice is when they are in the hospital and they are going for investigations, right? So typically they have to be NBM prior to some investigation. Investigation ke liye chale gaye, it's like taking 3 to 4 hours, and you actually see there is almost a 6-hour gap in their dietary intake. And this again impacts, if it happens over, in 5 days of admission, if it happens in 3 days, 3 or 5 days. So that's a substantial reduction in the overall protein intake. And then there are other myths. The moment you have WhatsApp, you have like WhatsApp forwards, YouTube University, and you also have Instagram schools, right? Everyone's telling them what to do. And this becomes a huge challenge. And typically, if you look at epidemiological studies, the moment there is an oncology diagnosis, they would veer away from foods that are rich in protein, and they would go into saying smoothies, vegetable smoothies, fruit smoothies. And those are, might be something that's like more in terms of the cancer preventive aspects, they suddenly start accepting. And you would see that there is a huge gap because of that in the protein content. So you have the food habits that you also need to address. Um, and of course, lack of knowledge. This also stems that they just don't know what's the right thing to do, which is where the nutrition education comes into place. And the one aspect that I'm quite sensitive about, given that that's why I work with an NGO, is primarily the economic aspect. Protein foods are not cheap. Okay, so they are quite expensive, and protein supplements can also become quite expensive. So they are already burdened with the treatment of the cancer of the disease. So it has to. So they think, okay, let me just take the medicines. Nutrition takes a backseat. So it actually becomes very important for us to tell them that you actually be able to do something about your cost of treatment if you actually take nutrition properly. So I don't work in a hospital anymore, but I do see private patients, and I do review a lot of patient like research data and stuff like that. And these are three things that I incorporate in my practice, which I feel are practical aspects. The first thing is, even though I did say that supplements are expensive and you need to give it, you need to actually be able to tell them that this is the only way that sometimes you are able to meet your requirements, because they are really, really a lot sometimes. Especially in the pediatric cases where the stomach is small, right? So you need to be able to give them low volume but high protein ONS supplements. In the adult cases, it could be that about the taste changes. They might one day like something, the other day they might like something else. So oral nutrition supplements become a fulcrum of nutrition therapy in oncological cases across the demographic. The second thing is something called protein counting. This is a terminology that I've made up myself, because when I talk to my patients, I try to empower them. Because every day their situation is different, and you can't expect them to come to you every day and tell them, okay, I ate eggs, you've told me to eat eggs in your diet plan, I don't like it today anymore. So what are they going to do? Sometimes they just don't eat. They say, okay, let me ignore it. Let me just leave it out. So what I like to do is I tell them that, okay, your target is 55 grams in today. Okay. Now, these are 4 or 5 things that you are allowed or you can take. So I would tell them that a medium-sized egg would be giving you around 7 grams of protein. Like, 50 gram paneer piece would be again giving you 7 grams. Like 100 grams chicken piece would give you 11 grams of 12 grams. And I say, this is your count. Now, in your protein, in each of your meal, you have a protein source, and count it. So this, what happens is, at the end of the day, so even if, like, say, sometimes there was this one patient of mine who used to go for chemo. She was a breast cancer patient, and she would go for her chemo, and then she would be actually sitting there and getting her outpatient, right, on outpatient. And outpatients, sometimes they don't get hospital food. So, and sometimes from the time they come home, they've not got a chance to pack their bags. So they miss a meal. And this is a time I usually tell them to take a ONS, because you're getting your protein at that point of time. And sometimes it also, they will not be able to meet up their requirements. So by evening, I say, take stock. Have you met 75% of your requirement? You have still 25%? Take that up at night. So this way you empower them, and they feel they are more in control. And then they are adhering to your diet. The third thing that I always follow, and this is my sports nutrition background that's come into play, is the timing of protein. I see that when I give a protein bolus at night before they go to bed, there is better anabolism, protein muscle anabolism. And this is something that I translate into chronic disease. So any case that I need muscle growth, I give them a bolus at night. There are many papers which have been done in hospitalized patients and NGT tubes. You can actually look at it and get more information about it. They do talk about 20 to 40 grams, which is might be a little too much, but then at least they establish the efficacy of giving a protein supplement at night before bed. So what more? So the first, when you started on, I showed you this. And you know, the human body is about 16% protein. But even though it's a 16% protein, it's so important. But it is not alone. It needs other things to come into the picture. Um, you have increasing amount of literature on amino acids, single amino acids, and glutamine and things like that, that actually helps. And this is something that I wanted to put it out here, but I have not really tried it out because the science on this is still coming out, and I don't have practical experience in it. But what I do have practical experience, and I usually tend to tell my patients to do, is start on omega-3 supplements, again, dousing the inflammation fire. This especially before they start chemo, because I feel once the train has gone out of the station, it's very difficult to drag it back. So I've seen multiple cases where, you know, start them on omega-3 supplements around 1,250 grams of DHA. Does help, but I always tell them to check with their doctor, because sometimes they don't want that to happen, and sometimes they think that if there is a conflict, I mean, there might be a drug nutrient interaction. So putting it out there, but always do check, ask them to check with the oncologist if it's okay to if it's safe to take it. The last but not least, the multimodal therapy. How much of a protein you give, there has to be some stimulus from the body saying, hey, I'm here. You need to come here from the digestive system, right? There has to be a sink for it. And physical activity is the only way. And you do see a lot of patients I mean, you might come and ask me, you know, they're bedridden. How do you even, how do you even make them uh, to be physically active? And we do have physiotherapists out here who can probably add, more to this conversation. But in my private practice, I've seen that resistance exercises really helps a lot. So there is a beautiful paper, which again I will show at the end of this presentation, which talks about the protocol that you need to follow, the FITT format that we normally follow in sports nutrition. That's being applied to pediatric oncology. And they also say what is the duration of aerobic activity, what is the duration of flexibility and coordination activity. But the one thing that is for protein to have an effect is resistance training, and these could be, through with exercise bands. It could be with weights. So there was this one boy who was about 15 years who had testicular carcinoma, and it was during COVID that happened. And he was losing a lot of weight, and I normally use MUAC as a measurement, not really height and weight. I keep asking them to asking them to monitor their MUAC so that I get an idea about the lean body mass loss. And we realized he was losing it, so, and he couldn't get out to do anything, right? So we used to use atta bags, like the and for weights. And these were some simple exercises, or he would actually use his own body for resistance training, and it actually worked beautifully. And I'm very proud to say that that boy went on to do his NEET, and he is a medical student now. So I really believe in the power of physical activity. So very key takeaways, which basically highlight the missing links. Malnutrition has a new definition. You have to consider the functional aspect of malnutrition, of nutritional status, rather than just height and weight. Look at hand grip strength. Try to incorporate it into your dietetic practice, because this is an amazing way to see whether you're on the right track. And with children, you don't have cutoffs, because it's still iffy right now. And sometimes you can only do hand grip above 10 years of age. But you can always do a longitudinal assessment and see whether the child is improving. And the third but not least is, the last but not least, is the multimodal therapy. Try to look at any of the other nutrients that support or synergistically will help protein do its work. And one of the other things that is important, and which you could probably send a referral to your physiotherapist in your hospitals, is not to do rehabilitative exercises, but more in terms of trying to see if you can build lean body mass. So these are some of the references of interest that I think you might really want to explore further, because they are a treasure trove, adds a lot of value, and I think you would really learn a lot from this, because I have not even taken like 0.1% from these papers. And that brings me to an end. So that's my media handles. If anyone wants to reach out to me, welcome to reach out to me. Thank you very much.
Thank you so much, Dr. Shripriya. That was such a comprehensive talk, and it gave stimulus to all of us to think about a few more missing points. Thank you so much. Now we have another very eminent, charming personality. So we have Miss Sunita as our next speaker. So she has 16 years of experience in the field of clinical nutrition. She is a gold medalist in the at the graduate level and a topper in master's program. Has been LLS certified nutritionist in ICU nutrition. She is a certified diabetes educator. She has trained herself in FODMAP diet from Monash University, Australia. She has worked in community nutrition program like Divine Month Mother and Child program and adolescent health programs involving rural pregnant women, infants, and children. She has co-authored in the book Nutrition Secrets, a nutritional guide to CKD, dialysis, and post-renal transplant patients. It's published in English and 8 other Indian languages, and it's an initiative from KWF. She also has co-authored in Healthy Renal Recipes, which provides curated kidney-friendly recipes for CKD, dialysis, and post-renal patients. Frequent speaker at corporate events, television and print media, she has also worked for betterment of nutrition in rural community. She has co-authored for the position paper, which is Perception of Protein in Critical Illness in Journal of Nutrition Research, that's Journal of J. Nutris. Received an award called Excellence in Clinical Nutrition from IAP in India. And her area of interest lies in renal nutrition, critical care nutrition, and community nutrition. Thank you so much for being here, Sunita. We look forward for your talk.
After the wonderful talk from Sri Priya, I'm so actually inspired by her talk that I hope I will. There are so many. That's one thing that I realized, that there's so many common aspects when you look at the chronic diseases. So the approach may be a little different, but then the sarcopenia, the cachexia,
No,
all those things we have to deal with when it comes to chronic
can you
disease.
help in the shift F5 is not happening? What happened? इथं F5 हाताची full screen दरवेळी येतं ना गं? या पुढे नाही.
So I'm so glad actually Sri Priya brought out this physical activity, because all said and done, even if your patient is very compliant with the protein intake that you plan for the patient, unless there is some kind of physical activity, it becomes very difficult to say that yes, whatever we are giving is getting translated into what it has to be. Yeah. So let me start. Actually, when again from Sri Priya, when Sri Priya mentioned King Charles and Kate Middleton, and the celebrities who have actually brought the nutrition. Oh, you can't hear me? I thought I was pretty loud. So when you look at the celebrities and then say, okay, when the community is now aware of what a patient with cancer, suffering from cancer goes through. I was wondering if we could pull out some celebrity who's undergoing dialysis, or somebody like that, where you can create better awareness in the community. It happens actually, and it's really good to, project it that way and create awareness. Otherwise, when you talk about organs like the heart, the liver, everybody knows it's a very important organ. Heart is a very important organ. But then the poor kidney is somewhere down, somewhere behind. And very often the question that people ask us is that, but we have two kidneys, no? What, like, if one fails, we have the other, right? So that is another common question that you are stumped when people ask you. And in the world, the prevalence of CKD is increasing. We have about 1 in 10 people who have been diagnosed of CKD, and we are not very far behind in India. We are somewhere around between 8 and 9% of our population who are heading towards CKD, and then with the increase in diabetes, I'm sure it's just going to increase, because we know that hypertension and diabetes and hypertension are the leading causes of CKD. Now, most often again, we really underestimate the kidneys. We feel that yes, it's an organ which excretes urine, it makes urine and excretes, but then it handles a whole lot of physiology there. And then if you look at this slide, you can really appreciate the amount of work that your kidney is doing for you. So it balances the sodium and the water, without which there would be hypertension and a volume overload, and that could in turn, affect the heart. It balances the potassium. So when the kidney functions are compromised and the kidneys are not able to excrete potassium, there is hyperkalemia. And we know that potassium is one mineral which is very essential for your muscle function. So all the muscle functions, and including that of the heart. So there is when there is hyperkalemia, there is extreme exhaustion, and then there is a risk of arrhythmia or cardiac arrest. One thing we all know, of course, is that kidneys play a very important role in eliminating the nitrogenous waste. So when that doesn't happen, there is uremia building up in the body, and that leads to a whole gamut of other things like the inflammation, impaired protein synthesis. There could be skin disorders, gastrointestinal manifestations, that is the patient has. When you see patient who's coming up with severe uremia, the first thing they tell you is that, I can't eat. Whatever you give, I won't be able to eat. So that is one thing. Then there could be encephalopathy. When the patients you see in ICU who have uremic encephalopathy, and then there could be sexual dysfunction. So you look at the array of dysfunctions that can happen when your kidneys are not working well. Another important aspect that again you are often asked is when you see a patient who has anemia, that is anemia related to CKD. They say the first thing that we have been taught right from beginning is, okay, you eat iron-rich foods, so that's going to help your, build up your HB levels and things like that. So they come with a lot of hope, thinking that, we can now, the dietitian is going to give us a list of foods which we can take, and then next time I come, my HB levels will be better. Unfortunately, that is another thing that, can't be entirely addressed by diet alone, because here the erythropoietin production is affected. So whatever amount of iron-rich foods you give from the top in your diet, it's not going to go down and form HB, hemoglobin, right? So that is another important function of the kidney for production of erythropoietin. Then there is the acid-base balance, which leads to, when that is upset, which leads to acidosis. And why are we concerned about acidosis? Basically, when there is acidosis, again, it affects the protein synthesis. So unless the bicarbonate levels are adjusted, you see bicarbonate levels somewhere at 15, 16, 18, then whatever amount of protein you give, that's not going to be converted into the nitrogen pool, and the albumin levels, nor anything, it's not going to really be functional. So first correct the bicarbonate levels, reduce the acidosis for the malnutrition to improve. Then there is again a very complex connection between parathyroid hormone, vitamin D, calcium, and phosphorus. All these work together to give you, the last set of, functions on the screen you see over here. So because vitamin D is not activated into the actual the form that needs to be, utilized in the body. Liver does half the conversion, kidney does the other half. So when kidney is not able to convert the vitamin D into its active form, there is vitamin D deficiency, so calcium absorption is impaired. And then again, when there is, low phosphorus excretion from the blood, because of the failing kidneys, this phosphorus combines with the remaining calcium and forms calcium phosphate. They go and form, calcifications on the smooth tissues. So all this is happening, and then we are trying to correct the diet, right? So one thing you have to be very clear about is there is no blanket diet for CKD. CKD, unfortunately, is it's a progressive disease. You cannot really say that once the patient has been diagnosed of CKD, you cannot say that, okay, there is a good hope of reversal. I mean, very few cases, maybe it was an AKI or some other reason, and then the patient has chances of, reversal. But otherwise, once the CKD is very well established, all that we should hope for and look at is to manage their nutritional status and maintain their creatinine levels as stable as possible so that they don't progress into end-stage renal disease very quickly. So at every stage of CKD, the nutritional requirement differs. Then it goes from the low protein requirement to the high protein requirement when the patient is getting dialyzed. And then there is this underlying comorbidities like the diabetes and hypertension which need to be addressed. And also, when you actually see a CKD patient in your clinic in the OPD, they may already be in the stage 3, 3B, and there is already pre-existing malnutrition. Again, as I said, the malnutrition, especially the PEW, the protein energy malnutrition, wasting, is multifactorial. As we have just seen, it could be due to the uremic toxins, it could be the systemic inflammation. That's what I was thinking. This inflammation is so common in most of the chronic diseases. So, and then when the patient is on dialysis, the dialysis treatment itself is a challenge because the kind of dialyzer, the membrane in the dialyzer that they use, or if there is insufficient dialysis, that could be a thing that is pushing patient into malnutrition. The quality of living as such decreases, and there could be, all these are actually leading to an increased catabolic state, but the patient is not able to eat. Again, the same scenario. So there could be metabolic dysfunction because of the hormonal disturbances that are there. That is, there is reduced insulin sensitivity, and then the leptin hormone is, there is suppression of appetite because there is an increased leptin sensitivity. So there are pro-inflammatory cytokines, and all this is again pushing the patient towards malnutrition. And superimposed on this is the fact that in most of the CKD patients, there is a gut dysbiosis. So again, I think this is an underlying thing in most of the chronic diseases. So there is this, in most of these patients, now when you say that you are giving this much of protein and you expect an increase in the serum albumin levels, you can't really directly expect that much of increment even if the patient is eating well because there is gut dysbiosis. So you don't know how much of what the nutrients that you give is getting absorbed. So I'm sure, I think in the next talk, Dr. Rehan is going to, throw some more light on the kind of dysbiosis that, chronic diseases, we have to deal with in chronic diseases. It's a very complicated pathway where, the protein synthesis is affected. I'm not going to really go into all the details, but let me tell you, the protein synthesis is affected and there is a protein breakdown. So it's like working in opposite directions, basically. Now, I mean, again, the sarcopenia. The major difference between the cachexia and sarcopenia, we see most of the, cancer patients having cachexia. There's like literally, they are skeleton. They're like, ribs and bones. But here in sarcopenia, see, sarcopenia actually is a condition which is normal in aging. As everybody ages, there is a little bit of sarcopenia. That is the muscle. There is a both functional loss of muscle and the loss of muscle mass also together, put together. So this frailty happens anyway with aging as we age. But then this is hastened when there is a chronic disease and when there is a sedentary lifestyle. Why are we talking about this as nutritionists is because when we tackle the patients, when we, talk to the patients regarding the importance of physical activity, especially in an Indian scenario, the moment patients are diagnosed of some chronic disease, they feel that it's over. Now they cannot do anything. They have to be taken care of. This mentality is something that they have to come out, and if they actually have to help themselves and get into that habit of physical activity which can reduce the progression of sarcopenia and muscle wasting. So all this has to be a part and the package of our counseling when we talk to these people. So overall, like when now I come to the specifics of CKD, the challenges are many basically. That is, first thing is you have to give them good nutrition, but then you have to look at the electrolytes. So you have to really choose the foods that you are giving. You can't really, give all the protein sources, because some of the protein sources, as you know, could be really high on phosphorus or could be really high on potassium. There is fluid restriction. So even when you are planning an ONS, you have to look at protein supplements which take just a small amount of water to, dissolve and then metabolize. Then again, there is a changing need of in the CKD. As you saw in the previous slides, the CKD is a progressive disease, and at each stage the requirement is different. Then there is an increased loss in conditions of in where the treatment of dialysis is happening, or when there is a patient is in sepsis or whatever, there is an increased demand. So, and also another challenge is that patients don't adhere to the nutritional regime that they are supposed to. That is a big, big challenge. You know everything, you've done everything, you've told them, but then if they are not adhering, it's very difficult. Then there are taste changes, basically, especially with salt. We actually want them to take less salt, but then the CKD itself is a condition where there is a kind of a dysgeusia, where the salt threshold increases and even the normal amounts of salt actually tastes less salt. That's another challenge. It is a sad scenario. And then there could be gastroparesis, so impaired gastric emptying could be there, making the patient feel full for a longer time. So if you want to plan a feed every 3 hours, they will be like, oh no, we cannot take any more. Another important factor here in India is that ONS is not covered by insurance, so whatever you plan, it's very difficult. And motivation. Last but not the least is motivation. Most of the patients you see in dialysis are like, done, I'm done, whatever. There is no motivation for them to you get up and set some goals for themselves, do some physical activity and follow the diet. I actually included this slide because this was very nicely explaining the diet considerations at each stage. I'm just going to make it very simple for you. So basically, in the early stages of CKD, what we see is that you have to address the underlying disease, whether it is diabetes, hypertension, obesity. That is what you need to, or dyslipidemia. These are the things that you have to address in the first stages of CKD. You're not going to directly jump into, potassium restriction, phosphorus restriction. No, it's not required at that stage. So follow a diet which is very close to a balanced diet, where the patient is actually getting the calories and proteins required, but then address the underlying, the disorder like the diabetes or hypertension. If diabetes is well controlled, you can, slow down the progress of CKD. Even if hypertension is well controlled, that also contributes. So that's how it is. And as we find a patient's EGFR is declining, that is when the electrolyte monitoring comes into play, fluid monitoring comes into play. So probably we would want to monitor the animal protein. So now the KDOQI guidelines are very clear. They are not telling you give this much protein, that much phosphorus. What they are telling you is you monitor the phosphorus levels, the potassium levels in such a way that the serum levels of potassium and phosphorus are within the limits. So they are not telling you give 800. Yeah, there is an arbitrary range, 800 to 1000 mg of phosphorus. But then you have as a dietitian, you have the freedom to, play in that range because you are monitoring the serum levels, basically. So that's one thing that we have to remember. Then, of course, when the patient goes into kidney failure and starts on dialysis, the protein requirements, it's another ball game altogether. The protein requirement, and then there is anuria, the fluid requirement. The fluids are extremely restricted for some. So, I mean, I'm sorry for this very, very cluttered slide, but then it shows you actually how the protein requirement for, or rather the nutrient requirement for each of the stages changes, and these are the guidelines. But then when you look at Indian population, the guidelines would very broadly say 25 to 35 kilocalories per kg body weight. These are just mere guidelines, and we have to be warned actually that, you can't, maybe there is a woman who is of the short stature and who has diabetes. Even if you start at 25 kilocalories per kg body weight, that might not probably be the calorie that she's been consuming. So just kind of titrate as per the case and then move forward. Let me make it very simple. As I have already previously said, then we have very distinct nutritional requirements in these three phases: the non-dialysis phase, the dialysis phase, and the post-transplant. So we all know, I'm not going to dwell too much into this because today I thought rather than talking about the macronutrient requirements and, the whole electrolyte balances and things like that, that we generally talk about when we talk CKD nutrition, I'm just going to focus more on those aspects that we in the hustle bustle may sometimes, overlook. So now moving on from this basic, demarcation from the different phases of CKD. So what would be the best type of oral nutrition support? That would be the one that actually the patient is willing to take. As I said, whatever you plan, if the patient is not able to take, then there is no use. So plan something close to the patient's reality, what he can, practically follow. That is one thing. Then if someone is eating poorly but has elevated serum biochemistry, so you see patients who come into the ICU, they have not been eating from 10 days, not much at all. They are just, living on some ganji, gruels and things like that. But they have a very elevated biochemistry, like potassium is high, sodium is high, everything is high. That's definitely not because of diet, isn't it? So that's something we have to realize. If someone is eating poorly and then if those patients who are just now, as I mentioned, the condition that I just mentioned, if they want a fruit also, you may probably want to, tighter the portion sizes of the fruit and feed him, because when somebody is so pathetic in their intake, something is better than nothing. These are the points that you start with when you actually start tackling a case of severe malnutrition. And renal specific oral supplements are useful. These are the times when you have to actually, these severe malnutrition, sepsis, and a period of long, a phase where they have not eaten well for a long time. These are the phases you should not hesitate to start an oral nutrition supplement. These are there for that phase, basically. So it has to be, but anyway, it has to be case based and so individualized. So the order in which you go, you generally, when your patient is eating well, you look for micronutrient supplementation. And then if the macronutrients are not being met, you go for oral nutritional support, enteral nutritional support if the patient is not able to orally take, and then the parenteral nutrition when the gut can't be used. This is some protocol that I think everybody in the hospital follows, right? So now I will move to certain things that we generally tend to neglect when we are, or neglect or overlook when we are counseling our patients who are quite stable. Now you see there are like sodium restriction is something that is very common in CKD. The first thing is that when in the conservative management stage, where the patient is, you have to start monitoring their salt intake, the potassium intake and things like that. If the patient is having proteinuria, but then the patient is not on too many, hypertensive medications, the BP is quite stable and there is no edema, then the patient himself or herself will say, madam, my BP is normal, I don't have edema, then why do I have to restrict salt? So this is a very common question, because restricting you, if you ask somebody to just quit eating something, like you say, don't eat green leafy vegetables, that's okay, that's still okay, they have a lot of choice. But in the whole diet pattern, a day's diet, you say, reduce the salt to an extent where the food becomes unpalatable, then that becomes difficult. That's really difficult. So then you are actually confronted by these questions, and that is when we have to remember that actually sodium restriction is not just required for reducing, controlling edema or controlling hypertension. It's also one way where you can actually control or reduce the proteinuria. So most of the CKD diseases that we see in India are proteinuric CKD diseases. So sodium restriction is important because it helps control proteinuria. There is enough evidence for that. And then when you see patients who are on dialysis, the next stage, this is when they come with volume over, suppose between two dialysis, they are supposed to increase around 2 kgs, but they increase around 2.5, 3 kgs. Then most of the time, the dialysis technicians will tell them, oh, you have had too much water, too much liquid, too much liquid. It might not be just the liquids, actually. It may not be that he's had too much liquids, but it would probably be the salt, which is, making them retain too much. And also, we had one patient, I had actually mentioned this to a group of my colleagues also. He was so desperate with the restriction, that the fluid restriction that he had, that he drank water from the faucet in the toilet. He drank, and in the middle of the night when he was not being monitored, he drank water from the toilet faucet. So that's the level you are pushing them. I mean, it's not necessary to go to that extremes, I feel. So try to monitor the salt and the fluid, because they always go hand in hand. If you're not controlling the salt but expect the patient to restrict fluids, it's very difficult. So this is another thing we have to remember. Always water follows salt. Now the fiber. We call ourselves, a very, very big vegetarian community in the world. We eat a lot of vegetables and things like that. But honestly, you do a recall, it's not true. Most of the patients you see, unless they are diet freaks, health freaks from the beginning, they will not be consuming good amount of vegetables. So the fiber intake in their diet will be pretty poor. So this affects our CKD patients in two ways. One is it could cause hyperkalemia, because constipation causes hyperkalemia. Because gut actually contributes to a good amount of potassium excretion when the kidneys are not working. So when there is potassium, when there is constipation, there could be hyperkalemia. And then another thing is the dysbiosis, of course. Now let's focus a little on the prebiotics and the probiotics, since we started with the gut now. So how do prebiotics help in CKD? They improve the transit time. They provide fuel for healthy bacteria in the gut. And this is so for everybody, not just in CKD. I mean, these are the benefits that we cannot overlook. Increase the fecal weight, aid in the calcium absorption. In fact, it aids in the absorption of nutrients in general. Then improve immune function. And there is also some evidence that increasing fiber intake may decrease the inflammation and improve mortality rates in those with CKD. So there are now all fibers are not prebiotics, right? As dietitians, we know that you can't categorize all the fibers as prebiotics. So there is like fructans, FOS, inulin, or oligosaccharides, then the lactulose, then the soya bean oligosaccharides, and the galactosaccharides. And these are the ones that you actually want to classify, want to see that you include in their diet. So as I said, when you actually look at the CKD patient's diet, for that matter, any patient's diet, their fiber intake would be really poor. So this is one slide I found where, you get some food sources of prebiotics. I mean, I thought this would be helpful. Now, we have addressed the prebiotics, then we move on to the probiotics. There is, now let us see what the evidence states in terms of probiotics in the treatment of CKD. What I found, actually we were planning a position paper or a guide and guidelines from IAPN regarding the role of prebiotics and probiotics and fiber in CKD, and we did a lot of a review of literature and things like that. And unfortunately, what happens is most of the literature that is there for the use of the benefits of probiotics in CKD is done in the for the conservative management stage of CKD, not on dialysis. That is one thing. And second thing is there is a lack of there are not many larger trials. So that is another two, probably the missing factors due to which most of the nephrologists don't believe in actively prescribing prebiotics or probiotics. There is a benefit, and it is linked with the quality of life and better digestion and better turnover of nutrients, but then it stops there. It doesn't lead you to the conclusion that yes, it is required and it should be a part and parcel of the treatment of CKD. I'm sure Dr. Rehan is going to throw some more light on that and why prebiotics and probiotics are, probably the way forward in, managing CKD and uremia to that extent. So having said that, how do we assess our success in managing CKD patients? If there is an improved overall intake, that is put together the oral, enteral and parenteral. If suppose you are able to give them the required, meet the requirement, then that's the first step. Then if there is a progression of nutrition support, that is you start withdrawing the support and then the patient is slowly starting to eat on his own, that is another step forward. Then the reversal of nutrient deficiency symptoms, then the patient reports himself or herself that there is better energy level, appetite, and the GI symptoms are taken care of. Then the biochemical parameters are better, not just albumin. So we didn't touch about assessment today. That's another whole big, topic to discuss. But when it comes to CKD or any chronic disease, there is no one parameter where you say, okay, this is our, nutrition marker. They're like a whole range of things that you have to measure and see if you want to measure the nutritional improvement of nutritional status. It could be the hand grip dynamometer, so that is improving, which is showing that the muscle strength is improving. It could be albumin, it could be the overall quality of life, and the SGA and the patient generated SGA and the malnutrition inflammation scores when it comes specific to the CKD patients. It's not just the anthropometry. Now again, we have our fair share of myths in CKD. I would have counseled them and told them you should eat dal, you should eat, because that's not the protein that's going to really bother your kidneys. Then they go back and after 3 months they come back and tell me, you told us not to eat dal. So what has happened in that period? They have gone through a lot of YouTube videos, social media, all that. So somewhere there, whatever latest gets impressed on their mind, they come back and tell me that you told us not to eat dal. So we had one patient who came from North, actually Delhi. He was a PhD professor, very learned man. But then he came on a wheelchair, advanced CKD. He came for he wanted transplant actually. So he had fallen prey to this myth where one of the somebody in there in Delhi had told him that we are going to cure you of CKD, and the diet that they had put him on was like negligible protein. So when he walked into the hospital, he was in the wheelchair, and he had to lean on his son actually when he had to move from department to department. It was a pathetic sight. And he refused to believe me when I told him that he should eat dal. No, nahi, creatinine बढ़ जाएगा. I'm not going to eat. So it was a head-on task for us as a team to, make him eat better. Then finally, he was much better. He underwent transplantation and is doing well. But this is what, these are the myths. This is the amount of damage the myths can do. Then they resort to, because no nephrologist will tell them that you are going to be cured of CKD, but they look for that kind of, answers. So they go to alternative treatments where that is promised, that if it is herbal medication, there is a risk of hyperkalemia. If there is, if it is some other alternative medications, there is a risk of heavy metals and, sudden damage. So all these have to be addressed in the counseling session. So these are some of the references that I used for my talk today. Thank you for the patient listening.
Thank you, Sunita, for touching. A very well-known person, Dr. Rehan, and he is an entrepreneur in himself and also a successful surgeon also. So we have an eminent cardiothoracic surgeon with 20 plus years of experience. Dr. Rehan is a founder of Motherhood Group of Hospitals, which is India's leading mother and child care hospital. He is an avid researcher with many firsts in his credit in the field of cardiac surgery. He is an elite athlete himself. He is a national medal holder in the sport of rowing and has represented the country in the sport of rowing for many international regattas. So regattas is a series of boat races. He is the founder of Wello'Tree, who is the whole sponsor for today's event and is focused in helping the community with better nutritional supplements that deliver as promised. His passion for sports has driven the sports nutrition vertical at Wello'Tree. We are looking forward to have you here, sir. Please come over.
I have been looking forward to these discussions for like 15 or 20 years of my life. Because when I came back from the US, I did not see anyone in any hospital in India even think and talk about nutrition the way you all are talking today. It was Greek and Latin to all of you sitting over here. If you talk about what's the calorie count, how much did this patient eat for the day, nobody knows. What's the diet you're giving? What's the breakup of the diet you're giving? Nobody knows. At the Cleveland Clinic and in Harvard, this is a part and parcel of my resident notes. I have to put it in my resident notes at 5:30 in the morning, and it will be vetted at 7 a.m. in the morning in my absence by the consultant on rounds and the team of clinical pharmacists, nutritionists, and everyone. It's mandatory, and I have committed on paper. I do not have a choice to go back on anything and make any corrections. And that was how important nutrition was to the American system where I trained and came from. When I came back, I did not see any of it, and it was not there when I left India. I trained at Apollo Chennai. It's one of the top institutions for cardiac surgery in the country and probably numbers wise even worldwide. But this was not a part and parcel of it. And now it's getting better and better. And even here today, as I stand in front of you, I can tell you we are still not where we should be in terms of nutrition. If someone is, especially now that the number of patients coming in are far more sicker, more chronicity of illnesses, longer ICU stays. It's all the more important that we start looking at it. And now I would say, okay, to some extent, yeah, it's much better, but still a battle that I keep fighting for is on the amount of fluid you want and the amount of calories I want, and how do we get this amount of protein in this amount of fluid, in this amount of calories. But I tell you, it makes a lot of difference because where I am today at Manipal Yashwantpur, at least around 60% of the population I'm doing is in the late 70s and early 80s. These are parents left behind by kids who are sitting in the USA and giving gyan from there saying, okay, go get it done. It's pretty sad, but that's the reality of the situation. And it's important for us as caregivers to ensure that we get them through the surgery and also get them through to a good quality of life, not just the surgery. Because if they get stuck, then they're going to get into all kinds of, hospital acquired infections or even community acquired infections, which today are quite varied and very different from the flora that we had like the pre-COVID era. The post-COVID era is a complete disaster on the community acquired infections that we have. So my presentation is basically giving you some case scenarios where I use my product in the belief that I've put something together in a direct head-to-head, because I've been using a lot of the other products in the market for a very long time, and I've never been convinced about what they give in reality, and that was why I actually put this together. And it was designed because I'm seeing patients who are coming in, struggling, and I have not done a sternotomy for like close to now 8 or 9 years. So I'm doing all non-sternotomy cardiac surgical procedures. So there's no fracture to heal. The pain is at its lowest. There's no logical reason that this patient should be getting stuck in the hospital and not moving around, because weight bearing, you name it, everything is permissible. So these people should get up and go, and they shouldn't be coming back. So this is the first case, an 83-year-old. This is almost a year and a half, or a year plus ago, I think. It was probably last July when we had this. Uh, Family of doctors, their father, they agreed to put the patient through surgery because there was no other option. Angioplasty was not an option. We did a cabbage, went uneventful, discharged day 5 for an 83-year-old, walking, climbing stairs, doing well, no problem. And he was a very functional 83-year-old coming into us. There was no problem at all. I think what happened was he had a chronic slow aspiration as he went home. They didn't realize it. And then 7 days later, he comes with florid, sudden acute. And then we took him through everything one by one. This is a lady I just did. She got discharged just 2 days ago. But with her, she was in bad shape. She had very bad, multi-drug resistant Klebsiella for UTI. So I took my time. I built her nutrition up pre-operatively. And then I did a mitral valve repair on her. That I do that robotically. And this is day 4 or day 5, and so birthday, and she's ready to go home. So I think the pre-op build-up was extremely important. I took my time. I made sure I got a negative culture. I made sure that all my parameters, especially nutritionally, she ticked all the boxes. And then she went through the surgery like a song. You will find a nasogastric tube in her, and this is to address the point that many of these people, they don't eat even though we want them to eat. Their intake is so poor that if you're going to bank, she's eating otherwise. But what I did was, what I do still, my practice is, I'll make sure I get my 1000 calories and my protein requirement with this nasogastric tube. You eat what you want. You take whatever you want, it's not my problem. So I know that I'm getting my nutrition in. So I'm sure that my patient's going to get what I need to get. And I was holding almost 1500 to 1900 calories in her, as in how she allowed us with, absorption, no distension and things like that. And we feed only in the daytime. If we're doing RT feeds, we do only in the daytime. We do not feed RT at night because we are still worried about aspiration. With the amount of churn in the nursing staff, You get absolute rookies on the floor who have no idea what's going on, so it's pretty dangerous, so we don't do that. And this is another case. This I brought out because of the HbA1c to highlight over here. And we've been running a lot of trials with all our patients on CGMs, and I can tell you confidently that with our product, you will not see a sugar spike at all. You will not see a sugar spike at all. And it has taken a while for me to convince my team of diabetologists, and some of them are very big names, both at Yashwantpur and at Manipal, and Hebbal, both of them, that, and then now they are convinced because they have all the patients on CGM on this product, they are not seeing spikes. But you do have spikes in most of the other products in the market because there is a significant amount of sugar sitting in those powders, whether you like it or not. You know, even if you say diabetic powder, it's still causing a spike. That's the truth of the matter. And we all know that hyperglycemia is poor outcomes or prolonged outcomes in the ICU. There is no two ways about it. You have good glycemic control, your ICU stay is pretty good. Everything gets better faster. So that's why I brought this case out. Post-renal transplant, we've been doing a lot of patients because Yashwantpur is a very aggressive renal transplant center. We do, I think, around 150 a year. Majority of these patients have coronary artery disease or something or the other that I have to. So we take them up, we do minimal access kind of work for them, and within 30 days we are able to get this patient back on the transplant bench. And that's only possible if we are able to feed well and take care of all this. So I work closely with the nephro team, and so since they are on dialysis and everything, we don't really hold back too much on the way we feed them. Because we have the ability to manage the fluid status, we have the ability to manage the proteins. So there is no logical reason to pull back too much on the feed that we are giving. So we feed well and we take care of those things. This is a guy who already had a first kidney transplant, then had triple valve, the deterioration. I did a triple valve replacement, non-sternotomy approach on him. And then he had some effusions, very typical, still taking time to settle down. But I think 45 days later, he was ready to go in for his transplant. He's doing very well post kidney transplant. And I think we have a nephrologist here. As a clinician, I would say transplant is actually a real gift to these dialysis patients. If you see them pre and you see them post, very often post-transplant, I walk past the bed because I can't recognize the patient. His skin texture, everything changes. The guy looks like he's brand new. Right? No, it's a huge difference for them. And transplant as such for all patients, it's amazing. It's something that we really need to look at. Uh, Reluctant for the she gave 3 sachets a day. She didn't even go with one. She said, if they tolerate, I'm going to go with 3. Is there any issue? I said, no, it's their absorption. So she went, patient did well, she got back to me, and patient continues to be one of our clients. I have since then also used it on these cancer survivors and also those who have cancer-driven cachexia or malnutrition. And I do see a significant benefit in terms of the muscle mass. They are not anymore, like skin and bones as we call it. Just, skin wrapped on bones, they're not that. You see some well-being and something coming out of that. And even chronicers like 84-year-olds, some of the dementia homes have now started using. If you walk into any dementia home, they're pretty much everyone's on something or the other. They don't know why they are on that, but everyone's on something or the other. And I think in some of them they have started using this. This is a feedback from one of those homes where one of the patients who was on a feeding gastrostomy on tube feeds, and they have used it. I have my own grandmother who is also a dementia patient. She has been on this now for a full year and a half from the very first sachet that we put together before we even came to the market with it. and she's doing well. I've not had any particular issues of any nature or anything like that. Much better than what she used to do. So this is as far as the patient's side of it is concerned. I put this product honestly only for them first when I started it. All the bioactives that kept getting added kept giving more and more goodies into this product. And then as a sportsman, I told my sporting community, guys, I have a product. Do you want to try it? And that's how it got started and tried. And it's rowing the sport which I'm in, which actually took it up in a big way. And then we've turned out not just national medalists, we've turned out Asian medalists with this product now. The last Asian Games, 5 medals, all of them on the product over there. What we see as athletes is the recovery that we see. Because we have quite strenuous, rowing is a very strenuous sport. It's a mix of a lot of anaerobic and aerobic, and it's not like an endurance sport. It is like not a sprint, but it's not endurance. You're stuck in between because the distance is like that, and it's quite a difficult sport. And what we are seeing over there is that every day we are able to come back and do that schedule with that same timing. Otherwise, 3-4 days into the schedule, we'll start dropping off. We are not dropping off. We are able to come back and do the same thing over and over again. And I think that's something that is seen. I have moved on to another sport, which is I've started trekking, which is a completely new sport to me. So new muscle groups, everything new, but I'm able to do the same thing. Like I'm able to come back the next. So if I do something on Saturday, I'm able to go back on Sunday and do the same thing. Like do a trek. So if I do say Madhugiri on Saturday, I'm able to do a similar size trek on Sunday morning, same speed. So that recovery was not possible earlier for me because it is quite grueling to do the same thing. And so I also CrossFit personally, and my community of CrossFitters are also using it. And this is the same thing that has come back to us. Much better recovery, reduced delayed onset muscle soreness. They are seeing an increase in muscle mass. Some of them used to take creatinine kinase as the main supplement. These are all the gym boys. And now they've out of the creatinine kinase, they don't touch it anymore, but they're still building muscle mass. They're using it because some of these guys go to bodybuilding competitions as a part of their thing. And then overall endurance is much better. For runners, we just started getting into that same thing, better recovery, less tired, no soreness, no cramps, and much better endurance. So I thought I'd keep this presentation basically because I have, as a clinician, for me it is imperative to see my patients go home. Just good surgery does not take a patient home. You need good physiotherapy, you need good nutrition, and I think what these hospitals aim for, which is ALOS, average length of stay, can only be cut short by these two departments. I have to do my job well. I can't create a complication, but it is not the all and end all of getting these patients home. And so these products, whatever we put together, are essential and a vital cog in the wheel for these patients to get home quickly. Lot of clinicians do not understand the dynamics of nutrition with a lot of the chronic illnesses and things like that. It is very, very important to go through that education process. We need to, educate. Even the intensivists, they are clueless about nutrition. If you go to them, they'll say, talk to the dietitian. They do not understand what nutrition does. And that's a fact of the matter. There are very few who understand nutrition in that way. And I think for me, that is the cornerstone. That's why we put this product together. We are working, and I can open it as a question to you all, is as someone who does a lot of heart failure, my need is 1 liter fluid, 2000 kilocalories, which means 1 ml needs to give me 2 kilocals. And I don't see any product in the market which I can bring and hang and give me that. So we are actually working on a hang bag which will be reconstituted at 1 liter, giving you 2 kilocalories with all the bioactives that you want. Hang it and go home. It should do the job for you. And that would be a thing because I have not yet gone. It's a mixture that is put together either from the kitchen with resource diabetic, with MCT oil, with whatever other proteins that you want to add into it, and that's how it's put together right now. Many years ago in the US, we had something called Novosource. It is not available anymore. But that came at 1 ml is equal to 2 kilocals. We used to hang and go. And that was very easy. I think it would be nice to have inputs from all of you on what is that you want in that 1 liter and how do we put it together. It can be done. We're pretty close to getting it done. But when we get the inputs, we'll get a good product. This product also is good because it had inputs carried out from your sides. The idea was mine. This is what I wanted, but executing it and making sure that it all works, it comes from teamwork. So thank you for that.
Thank you, Dr. Rehan, for touching upon the real case scenarios. So we had all three speakers who spoke in their field of expertise. So me, as a bird point of view, I'll be just touching upon as a clinical dietitian, not only oncology or CKD, I'll be just looking upon all the cases. I'm not going to take much time. I'm very conscious of time, just 10 minutes or lesser than that if possible. So the challenge is why the requirements are high and what could be the solution. So I'm not going to take much time in that. Time goes in opening and closing. Yeah. So basically the topic we all know today is we are trying to find out what's the missing link between the requirements, the demand and the supply, right? So there are factors which are majorly dependent. We know what is the, of course, the requirements are high, but why? First, probably the disease condition. So as you all, as the speaker said, a CKD patient coming with sarcopenia. Yeah. This one is not getting it. I got it. Okay. Got it. Yeah. Thank you so much. I wasn't able to see the cursor moving, sorry, so that's the problem. So the disease condition itself may be the first thing. So a CKD patient with sarcopenia or a oncology patient with cachexia or a patient who has undergone a surgery and is waiting for the wound to be healed. And there are many other, even a patient with DKA with so much of acidosis, alkalosis. I mean, there's a concoction of different diseases that happens. I'm speaking more from critical illness. Whatever I speak, I somehow slip into critical illness, sorry. So, but that's where patients end up, right? So my point of view is from there, but I'm trying to see an overall picture. Okay, so it's the first disease condition itself which drives a patient into increased requirement. Metabolic changes, there's a lot of metabolic changes. There's increased requirement. Why? There's a reduced anabolism of protein. Basically, we call it as reduced response to protein anabolism. There's a lot of saturation which happens. This especially happens in an elderly patient. So even if there's a lot of protein, he is not able to absorb it. And there's something called as planktonic sequestration. Basically, the amount of amino acids which the gut draws towards itself is more. So it leaves very little protein to be absorbed by the muscle. So the systemic flow or the circulation is less. So a lot of protein is already utilized by the gut and the muscle building gets compromised, right? So that is the metabolic changes. So what happens? Reduced anabolism, more of catabolism, it drives towards net negative nitrogen balance. That's the problem, right? Then reduced intake, we know this. And atrophy of muscles, that happens, right? Any patient being immobilized on the bed for many days on a bed, that leads to muscle atrophy. So there's a lot of muscle wastage that happens. Every patient post RTA, that means road traffic accident, he has not been able to move for a long time. Every day he might be losing around 5% of his lean body mass. That's why physiotherapy is that important. As soon as possible, patients are tried to be mobilized the day as soon as it's possible, any procedure, depending upon the patient's tolerance. Then cytokine production due to trauma, infection. So we know inflammation Any inflammation, there are so many inflammatory markers which gets produced. So there's a TNF alpha factor and IL-6. So that also drives into increased energy requirements, reduced synthesis and malabsorption. So even if you're giving 100%, if the patient is able to take 60% and the absorption is only 10%, then what's the use? So these are all the factors which increases the requirements for a patient. So we know the requirement is high, but what's the reason for a compromised nutrition status? Again, the disease burden, so metabolic dysfunction is there, uremic toxins, for example, a patient who hasn't been dialyzed for a long time for some reasons, there's a toxin which is getting built up, which is affecting everything. Then alter gut flora, which has been already addressed, hormonal disbalance, gastroparesis. So patients, the muscles become sluggish. For many patients, the stomach muscles have become sluggish. The food is not moving from the stomach. So they'll feel sluggish, right? Their appetite comes down. They're not able to even pass motion, right? So this all definitely alters the patient's intake. So he wouldn't feel hungry at all, no matter how much you insist. They say, I just can't eat, right? Then increased nutrient needs, wound healing. We know that for any procedure, there's a lot of requirement of protein for the patients to heal. And then infection, inflammation, sepsis, all that. Repeated hospitalization, we see usually with the CKD patient, onco patients, they will be coming back for some of the other procedure, or probably negligence. So by the time they go back home, within a week or 15 days, they come back. There's hardly much of time for them to recoup back to their original status, right? So that could be one reason. Underlying comorbidities, improper replenishment. Obviously, when they are not spending much time at home only, they are still taking time to come back to their normal status. There's very little replenishment which is happening. Less compliance on diet and treatment. We have come across, it could be financial burden, it could be their own misconceptions. There's less compliance. Obviously, that ends up in compromised nutrition status. Reduced intake, many reasons, we all know that. So it could be anorexia because either medication, surgery, or chronic illness. And reduced palatability because of medication or disease condition or non-familiarity of the food. Even if there's a dyselectrolemia, because if the sodium levels are low, they may not find the food palatable. The food which is tasty to you and me, they may not be feeling the same. The perception changes. GI factors like nausea, vomiting, constipation, loose stools, these do affect, and that could be for many reasons, either oral intake or enteral feeding. It can cause any of the GI problems. Changes in sight, taste, smell, poor dental condition. Usually more happens with elderly patients, and most of the critical illness patients, many of them are elderly people. They also will have swallowing difficulties. Then, as already told by other speakers about the self-imposed restriction due to immense flow of advices from everywhere, because it would be the last person that they come to a dietitian. A plumber would be visited once there's a plumbing issue. A maintenance guy would be called if there's a maintenance issue, but the dietitian is always contacted at the end, because they will go with everyone, doodh wala, ghar wali, kaam wali, everyone will give all gyan, but at the end, someone will tell you have to ask a dietitian, they may come. And then misconceptions, everybody have their misconception. They believe more, probably, any diet which is with a lot of fancy names and, a lot of restrictions is always found to be very attractive. Someone who charges a lot would be always very attractive rather than one who give a lot of gyan free of cost. So this misconception do prevail everywhere. Yeah. Then increased requirements, I'm not touching again. Financial burden, either to treatment, the nutrition supplement, sorry to say, but yes, still it's very, very costly, not affordable by all. Correct? The moment we say, probably they may take it for, because of our pressure, probably 15 days. Later, they may try to go for some ghar ka khana only. So nutrition supplements, of course, we are not telling that they have to take lifelong, but till the time their body is ready to support the requirements, they have to take it, right? And depression, self-feeding issues for elderly patients, or those who are suffering with issues, dependency, if they have lost a partner, a spouse, dependency on in-laws, kids, and everything. I mean, there's so much of dependency to move around, and they may be in an old age home. So all these challenges will be there. So what are the solutions? Basically, we shouldn't be only talking about the problems, but the solution should be discussed. So solutions for those on an oral diet, especially as much as possible in all the hospitals, doctors should try to refer a patient to the dietitian for a pre-op. Anywhere wherever it's an elective surgery, if pre-op nutrition counseling is done at least 21 days or 3 or 4 weeks, it will help a lot in the outcome, surgical outcome, medical outcome, for everything. If the patient have a good nutrition status, it's really going to help the patient. For the doctor, for the hospital, definitely is going to help. Encouraging small frequent meals if the patient is feeling satiated very fast. Addressing all the GI issues. There are many things, there are many small steps which can be put in practice and where we can try to address what is the GI issues. Of course, if it's a gastroparesis, we can't do much, but there are some simple bloating, long stay of hunger. There are many things which we can help a patient with. Providing nutrient-dense foods in appropriate texture and in appropriate temperature, which is very important, because no matter what we talk, it has to be boiled down to a practical thing. Food which is balanced in diet also has to be in a texture which can be well assimilated. A normal diet probably will definitely cannot be taken by a patient who has no denture. So a soft diet along with the temperature, a cold food will not be relished by anyone when their appetite is already low. Then avoid imposing unnecessary restriction, which I already told, because this we usually see with CKD patients, their attenders, out of love, they try to do so much of a restriction. One has to be practical enough to see, okay, if 100 grams of this particular food is giving so much potassium, it's not that he's taking whole day the same thing. One has to be just considerate that how much actually is he taking? Is it really going to harm him? Rather than pushing him into depression, we should be helpful, giving more options rather than being restrictive. Include ONS, oral nutrition supplements, to make up for the nutritional gap. And encouraging the patient with small rewards. Someone who is being a long stay patient for 2 months and all that, try to see how you can help them with small rewards, means through food only, right? That can be done. And if it's a patient on, this is the last slide, if it's a patient on enteral feeding, long prolonged NP hours has to be avoided. If the nurses have forgotten, or probably there's a gap in raising the diet, it has to be minimized because the patient is losing on so many energy and protein. Avoiding withholding of feeds just for small gastric residual volumes has to be avoided, because our body secretion itself will be around 200, 300. So just for GRVs of 200, we should not be holding the feeds. We should continue. We should just find out what's the reason and do a fix for that. Choosing an appropriate feed formula for increasing the tolerance. Obviously, we'll always go step by step, even if there's an intolerance, what permutation and combination we can do to meet up the requirements. Choosing and making combinations of formulas, that's what I said. And proper route has to be chosen, which obviously doctor will do. If the patient is not tolerating NG, probably go further down and NJ might be required. And a well-coordinated interdisciplinary approach, because it's always good to be in touch with all the people, physiotherapists, nurses, doctors. There'll be something which is missing. There's a lot of communication gap. If we fill up those gaps, the patient is going to get benefited. That's all I had. I think I wanted quite fast. So that's all from my side. And we are actually moving to a panel discussion now. But before that, I would want to call upon a very, very eminent speaker, and that is Dr. Dinesh. He will be a part of panel member, but I would want him to come and also speak over and express his views. So Dr. Dinesh, he's a renowned nephrologist and transplant physician with more than 13 years of experience. He completed his MD Medicine and DM Nephrology from MS Ramaya Medical College, Bangalore. Post his DM, he worked as HOD and senior consultant in the Department of Nephrology at St. Martha's Hospital for 9 years. He holds his expertise in managing complex kidney disease issues from AKI and to CKDs. And he has been, his area of interest has been in clinical nephrology with expertise in procedure like native kidney biopsies, graft biopsies, temporary HD catheter and permacath insertion techniques. He specializes in both live related and deceased donor renal transplantations. He specializes in managing critically ill patients on CRRT or SLED. He has extensive experience in managing renal tubular acidosis, electrolyte imbalance, renal stone disease, and complex UTIs. It's an honor to have you, Dr. Dinesh here. I would want you to please express your views on this.
Thank you. I don't have any slides, okay? So I'll go with, I won't take much time, maybe 5 minutes. So anything is there, if you have anything related with nutrition in CKD, you can ask me. I think Sunita Rao has spoken well on the CKD and nutrition, so I don't want to waste time. We'll be discussing in a panel discussion. So as you know, CKD is a chronic kidney disease which which lasts for, if we see any deranged parameters like increased creatinine or blood urea or proteinuria in the urine, or when ultrasound shows small kidney for more than 3 months, we call it as CKD. And CKD, diet plays an important role in in management of CKD. It acts, it can be a miracle in preventing the progression of CKD, both in, especially in pre-dialysis and before dialysis. So, as we know, the most common cause for CKD patients are diabetes, and we are known for we Indians are known as India is known as the diabetic capital of India of the world, and diabetes constitutes around 50 to 60% of CKD in India. And next is hypertension, and next comes congenital heart disease, recurrent infections to the kidneys, continuous painkillers which can cause kidney problems. So all these are the causes for CKD. And when can somebody say we will not be knowing that a patient has CKD in the initial stage. Stage 1, stage 2, stage 3, patient won't have any symptoms. Only on doing a blood test or urine test or an ultrasound, we will get to know that patient has got a CKD. Because initial stage, even the creatinine of 2 or 3, a patient won't have uremic symptoms. So only at the later stage, after stage 3 or stage 4, when the urea starts building up, then we will get to know that patient has got CKD. CKD, and we try to actively manage that. So when we see a CKD, say even if the creatinine is normal, patient can have CKD, like long-standing diabetes or hypertension. If there is some end organ damage, like retinopathy is there, or urine is showing some proteinuria, then we call it a stage 1 CKD. In stage 1 CKD, diet management, the most important is low salt diet, and whatever the culprit, if it's a diabetes, then diabetes has to be controlled, and if it's because of hypertension, then we have to target the hypertension. So initial stage, we don't restrict the protein as we see in the stage 3 or stage 4. So initially stage 1 and stage 2, we will give a normal protein depending on the patient's workload. As CKD progresses, like stage 3 and stage 4 or stage 5, who is not on dialysis, then the protein intake, we have to concentrate on decreasing the protein intake. Usually we give around 0.6 to 0.8 grams per kg per day of proteins. Preferably plant proteins, because when we give animal proteins, there will be buildup of acids. So preferably we give plant proteins. And as KDIGO or any other guidelines, they say high quality proteins are better. So what are these high quality proteins? This is egg white or chicken breast, or whey proteins with low phosphorus, low potassium. These are considered as high quality proteins for CKD patients. See, not all the patients we have to restrict the potassium, not all the patients we have to restrict the phosphorus. So only selective patients, especially if the patient or on some medications which can increase the potassium, which medications which acts as a renoprotective medicines which can increase the potassium. But these medicines are essential. In that case, we have to give a proper diet. So you know, I mean, everybody knows all the food contains potassium, but more potassiums are in tomatoes, potatoes, uh, 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 tender coconut water. Uh, so all these things we tell them to restrict. In spite of that, if the hyperkalemia is there, then we add some medications like K-bind or some fluorocortisone to reduce the potassium. Phosphorus, again the phosphorus, uh, we have to restrict when after the stage T, stage 4, there is a build-up, there is below hypocalcemia and there will be hyperphosphatemia, and this leads to bone disease. And hyperphosphatemia will cause as well as bone problem, as well as it causes cardiovascular diseases. So in this case, we have to restrict the phosphorus. So we know the phosphorus are in animal products, are colas, nuts. So all this, see, these are the challenges what we face whenever we manage the CKD who are not on dialysis. So we have to restrict potassium, we have to restrict phosphorus, we have to restrict the salt, we have to restrict the fluid intake. Not all the patients we restrict the fluid intake. We see the patient is accumulating fluids. Is there is a pedal edema. Those who have got glomerular diseases, most of them they need fluid restriction. But if the patient has got interstitial disease, they don't need any fluid restrictions. So each patient is different, and each patient diet management has to be tailored. I think we will be discussing this everything in the panel. So any questions regarding CKD, you can ask me. See, this protein restriction is mainly in stage 3, stage 4, stage 5, not on dialysis. But once the patient lands in dialysis, then the protein has to be intake has to be 1.2 to 1.5, 1.4 grams per kg per day, preferably high quality proteins. Okay, thank you.
So thanks for that, Dr. Dinesh. So I request all the speakers to please come over the dais for the panel discussion. Dr. Shripriya Sunita, Dr. Dinesh, Dr. Rehan. Audience also, keep your questions ready. After the questions that we are going to ask, you may also please feel free to ask your questions. Okay. They may use it? Okay. Sure. Thank you.
We have to announce that there are almost 30 to 40 people watching online. So, yeah, we have a larger participation on online.
That's been easier way for them.
By sharing and YouTube link, live streaming, it seemed easier to do that. So I have a question actually once you have from one of the
Sure.
online viewers.
So my first question will be for Dr. Shripriya. So it's about, okay? Okay, am I okay now? Audible? I'll keep it hold. Am I audible? Mic was not working. Okay, so my first question for Dr. Shripriya. Yeah. So it's about cross disease insight. So what can we learn from the nutritional management of cancer that can be applied to CKD as well, and vice versa?
Thank you so much. I'm audible, right? Yeah. Okay. Thank you so much for this. So, as I was listening to Sunita, right? I mean, I think a lot of things I felt it was like a lot of similarities was happening. And one of the things which really struck to me was, of course, like the nutrition assessment and the importance of maintaining the nutrition status and starting early. That was one thing which I think both of, that's an issue with both CKD and cancer. And the other aspect which, and protein, of course, protein has a role in both. Although in cancer, though we keep the protein throughout, consistent throughout the treatment, whereas in CKD you have the, the dips and the, when as it progresses, you will have to keep titrating the protein dose. But in both cases, we are giving the right amount and high quality of protein to maintain and improve the quality of life. The third thing which really struck me, and which I didn't really cover about, is like where the phosphate and the phosphorus, the restriction of the phosphorus and the kalemia. So there is a situation in cancer that happens typically in leukemia, and usually during the induction phase, wherein there is a lot of tumor lysis. So it's called as a tumor lysis syndrome or the TLS syndrome. So the TLS syndrome, if left unchecked, can be fatal. And it really progresses very fast. So typically there are these also high risk, so there are certain drugs that are known to cause TLS. So where you have the high risk TLS cases, and it will be only, but unlike CKD, where it might actually go on for a longer time, your restrictions of your phosphorus and your potassium and all, this could be very transitory till probably the tumors that have broken down inside the body and have given out all the cellular contents are like kind of moving out. It will be a very transitory phase. So again, the restrictions on the thing that we learn how to control these at CKD would be applied to cancer. And I think, but at the end of it, one thing that ties up like this entire, all the chronic diseases for that matter, is the importance of the nutritionist in providing the nutrition education, empowering the patients. And of course, I think we've had Dr. Rehan, who's like, I think, a champion of nutrition. And, it's very rare to get doctors who actually appreciate or who give you that, like understanding. So I think it's very important to be constantly talking to the doctors, sharing, resources and all, and getting them on board and doing it as a interdisciplinary team.
Very
Thank you.
true. Very true. So second question also for Dr. Shripriya only. I'll finish with you. This is about gut health. Yeah. So how do you like different types of cancer treatments, like it could be chemo, radio, hormonal treatment? How does it impact the microbiome and overall gut health? And what are the long-term consequences of disrupted gut health after cancer treatment?
So, so the cancer and the gut dysbiosis is something that is like, it's like a chicken and egg story, right? Sometimes it says, is the gut biosis causing the cancer, or is it, I mean, of course, everyone knows that with cancer treatment, the gut definitely goes for a toss. And given that, there is a lot of immune system involvement in cancer, giving any probiotics, especially when there is a BMT, when there is bone marrow transplant, prescribing a probiotic or a prebiotic sometimes, or even fermented foods for that matter. Forget about, going to supplements. Even like a simple fermented foods of like, say, curd or something is a question mark. It's a Pandora's box. You would have one, a transplant unit saying, I absolutely, no, absolutely don't allow. Whereas you would have other centers where would actually say if it's a single-use container which is pasteurized, that's allowed. Some people are really, it goes, there might be like at CAR-T therapy instance where even supplements are not allowed, and they would actually say, every time you open and scoop it in, there might be a chance of contamination. So the entire probiotic or the gut story with cancer is like, it's like it's a question mark. But what we can definitively say that yes, chemotherapy, radiation, surgery does impact the gut diversity and the gut microflora, and you end up sometimes having short-term impacts on the gut, which like antibiotic resistance, diarrhea, things like that. Whereas sometimes you have like there is something called as like functional redundancy in the gut, which basically means there is a whole bunch of microbiota which do the same function, and this actually is very helpful when there is a disease condition. So if one particular organism is affected, the other one kicks in. And sometimes there is this loss of functional redundancy, which is actually can impact the overall gut. There is also certain types of when the actual which is a beneficial microbiota actually turns pathogenic. Those are the kind of changes also that happens with radiation, and these typically happens with chemotherapy. With radiation, you might have like the radiation enteropathy, those kind of things which cause, continuous diarrhea and things like, like which is associated with absorption. Long-term effects, because of these changes, even after they finish their treatment, they might sometimes continue having a weaker gut. So any small things can still trigger a gastrointestinal issue or chronic diarrhea.
True. So even common cells turning into a harmful microbes, that also can happen. True.
Thank you.
Thank you so much, Dr. Shripriya. Now the questions for Sunita. So we would be hearing so much about the importance of plant-based diet for CKD. So what are your views on this?
Yeah, well, actually, this plant-based diets or Play-Doh diets that they are termed as became popular sometime about 5 years ago in the West. That is when the West that has a predominantly meat based diet started realizing that somewhere down the line, if they increase their vegetable intake, fiber intake, there seems to be a benefit for the CKD patients in terms of, reduced uremic toxins, reduced production of cresol sulfate and indoxyl sulfate and things like that. So that is when the team of researchers started coining this Play-Doh diets. But then if you look at our Indian diets, we have always mostly been plant dominant based, diet culture. The culture of our diet is most of the time the plant dominant, basically. Even if they are non-vegetarians, what they don't eat every single day, and they don't eat non-veg for all 3 meals of the day. So even when you talk about the benefits of plant-based diets, there is a balance. It doesn't mean that you need to turn vegan for reaping the benefits of Play-Doh diets. It just means that there has to be a a balance between the plant intake of plant sources and the good quality proteins. And in CKD, as we were just discussing all these in all the talks, each case requires a different amount of protein, and so based on that you plan the diet. So definitely include the plants for the benefit of their fiber. And there was another myth, basically, even now there is a myth amongst many doctors per se. They will say if you increase the amount of vegetables in your diet, then you may have hyperkalemia. But that's not the thing, because the vegetables come with fiber. So the fiber in the vegetables actually prevent the absorption of potassium to a great extent. So that, in fact, when somebody is suffering from hyperkalemia, the first thing that you have to look at is he having constipation? So that is, so this way Play-Doh diets are, I think in India, we are blessed with this combination. So just make sure that you see that the patient is getting enough of fiber in the form of vegetables and plant sources.
True. The absorption of potassium is very less
through the
plant-based diet. And again for Sunita, how do you meet up the requirements of a patient who is on dialysis, the protein requirement by a vegetarian?
Yeah, that is a challenge. So we have been discussing again that when the patient is on dialysis, there is a sudden transition from a low protein diet into a high protein diet. So now, actually, when I talk about guidelines, the KDOQI guidelines earlier, 10 years ago, said that it is 1.2 grams for hemodialysis and 1.3 for peritoneal dialysis, because the protein wastage is higher in peritoneal dialysis patients. But now what it has said is, in the 2020 guidelines, it says anywhere between 1 and 2 grams of protein per kg body weight. But again, you have to take it case-based. If they're already malnourished, if there is, during the last phases of the end-stage renal disease, they are always extremely malnourished. They wouldn't be eating well. So there you have to actually catch up. So you might actually land up giving 1.5 grams of protein per kg body weight. You may want to give. But if the patient is a vegetarian, it is absolutely impractical to plan all those grams of protein through a plant-based diets, unless you are, the patient is able to eat volumes. So because that is one disadvantage in, plant-based proteins, the volume. If the patient is not able to eat the volume, then it's very difficult. ONS is the go-to. At least what we do in our center is we coax the patient to start eating egg whites, which is the ideal protein supplement for dialysis patients. So either start an awareness to bridge the gap, or hope that the patient eats, egg whites, and then plan the rest with the plant proteins.
That's pretty a concentrated source. Yeah. Thank you, Sunita. Now is for Dr. Rehan. So how much is the bioavailability of nutrients from a nutrient supplement? Because you will be knowing more than us because you have been in industry of the actual manufacturing of the supplements. So theoretically, it could be something else, but practically how much, probably it's not only protein, all the nutrients per se.
Yeah, I think that goes, it is like, I would say, three factors. One is, where is your source of this nutrient coming from? Is it a natural source or is it an artificial source? Natural sources are better bioavailability in natural sources, but they also come at a price. And the artificial sources have their own issues, contamination or whatever other things that we are going to be dealing with. That is one of them. Second is the patient factor itself, the interaction of this uh, ingredient, whatever you're taking, and each patient's ability to absorb differently. Not all are same. Everyone is different. And then when you put a product together, you have so many ingredients into that product, and you're trying to put all these products in one place, make sure that every one of them is delivering as promised. That's also not that easy to get. Like, if you will not get the taste in some, like when we put this together, we didn't want to cut back on using curcumin. We didn't want to cut back on using lycopene. And in the first product, I remember that we brought to the market, the color change when you actually mixed the powder and left it into atmosphere, the air and the interaction of the air with lycopene and curcumin gave absolutely a blood red change to the color, right? And everyone was worried, like, what's going on? Is this protein denatured? Is this bad? Is it gone bad? But that was all it was. And when we went back and we figured out what it was, and then we changed from regular haldi or curcumin to white haldi, and lo and behold, this color change disappeared. Okay, because of the interaction. So, like, there are so many interactions. So, it's important for us when we put a product together to also keep in mind these, so that we are not short cheating one for the other. Like, if we're saying we're giving you so many bioactives, then we should give these bioactives, which is the biggest problem today. And now, today, suddenly, after eons, ICMR is waking up and saying, this is not, it was never there. Where was it to start with? It never existed. And now you're telling it is not there because you're looking at it. Even today, FSSAI doesn't test anything. Do they ask for any testing? Zero. If I want a product, tomorrow morning I can go to FSSAI, pay 1,500 rupees, he'll register my product and give it to me. And he's telling the market and the press that he's the most rigid testing authority today, which is pretty sad, and it's all lies. So I think fundamentally, the onus stands on the producer. You know, what are you going to put to the market and why are you giving it out there? So bioavailability is based on your source of where you're getting it, is on the amount, the ingredients. You should have some knowledge about it, and I think that's why it's important. I owe whatever I put together to Anjana, Priyanka, and the team, who actually guided me, saying, this and this is not going to work, but these two will work. I've had issues with them over even the protein content, but they stuck to it and said, if you want all your amino acids to be there, this ratio is mandatory. Because as a doctor, I don't understand that depth of it. But that's your domain strength. And to be able to understand that, it's going to take us a long time and things. So I was banking on that. And so that's how this whole product came together. And finally, it's also the patient factors, right? So after you put all this together, each one absorbs differently, and you have to keep that in mind. So if we can get out at least 80 to 90% of what you're putting on label claim as your deliverable, I think you've done your job. You may never be able to accomplish 100%.
I definitely agree. Even with the last point about the patients, I mean, we can say for FMCG companies, they'll call as clients, or here we call as patients. So they'll obviously see what are the factors which increases the acceptance. So anything which is very nutritious will not be palatable. So they have to add a lot of fats for a high fiber biscuit for it to be acceptable. So same thing goes here as well. Thanks for that, Dr. Rihan. Oops,
The volume on the mic, just increase the volume on the
it's
mic.
maybe mine problem only. Okay, I'll hold it a little bit near. Okay, and what policies at the government level or by the manufacturers, again to Dr. Rihan, can help the supplements be a little more affordable for, by general public?
I'll break that also into three places. So one is government. They have an 18% GST on a nutritional supplement, which is pretty sad because you're never going to be, and in a country where malnourishment is enough and plenty. So even if an NGO wants to come and help, he will think 10 times because he's paying 18% of whatever money he's putting into tax for somebody which is not even being used constructively. That's a different issue. But 18% on something like this, I think it is huge. And then if you're a lot of India, Nutra and Pharma depend on the outside world for their APIs. We are not self-sufficient in the production of ingredients or high quality ingredients in our country as yet. If you want to good quality ingredients, you have to look outside. So when you export ingredients in order to make it together, that also comes at a high customs duty, and that adds cost which can be avoided if they understand why are you doing it. I mean, yes, everybody is in business to make money, but they need to understand what is the need for the country also. If they get nutritional supplement cheap, then at least if you're not able to provide food as in food, you can at least try to compensate somewhere or the other. Because every time you just can't keep providing food, it's not logistically possible, and there's a lot of other issues that doesn't allow food to reach where it has to properly also. This is one where the government can come back on taxes. The second thing is the hospitals themselves. So if you're under the assumption that what we put on the MRP is what we are getting, oh, it's very very far apart. So it's some of the reasons. First of all, the MRP itself is dictated by the hospitals. It's not even we who choose the MRP, and what the patient is paying is the MRP. So as a manufacturer and as a producer, I don't have 100% control on my own MRP. If I have to be in the business, I have to listen to some of these giants in the corporate sector who dictate MRPs in order to make whatever margins that they have to go to. So there can be a little give and take over there. I know there is margins to be made for them and everything, but I think there is room for some negotiation. There's room because if they are willing to take a little bit of hit, then the overall cost or the MRP can also come down, benefiting the patients in a lot of way. I think these two itself are big hurdles for us to deal with. And FMCGs are different. I mean, their way of looking at things is entirely different. If you go into the nitty gritty of that, it's you will not even want to touch the product.
It's really a sad scenario. Thanks, Dr. Rihan. Now that's a question for Dr. Dinesh. Actually, Dr. Rihan also had touched a bit on that. Dr. Dinesh, what are your views on the recent guidelines by ICMR on protein supplements, also in relation with renal patients? So probably someone who has undiagnosed kidney issues, probably.
There is recent update by ICMR is mainly they have concentrated on appropriate protein supplements to all the populations, including patients who have chronic disease like malignancy or CKD patients. In CKD patients, as I said, pre-dialysis those who are not on dialysis are initial stage, stage 2, stage 3, stage 4. The guidelines says we have to give around zero point 0.6 grams to 0.8 grams per kg per day. But each patient, we have to assess them, and we have to keep on doing blood test and see the nutritional level as well as see the renal function test, and then we have to manage that. So when the patient is on dialysis, then the protein intake will obviously increase. It has to be 1.2 to 1.4 grams because this dialysis patient will lose a lot of amino acids, as well as dialysis itself is a catabolic state. So in this case, they need high quality proteins. So preferably ask them to take chicken if they are non-vegetarian, but unfortunately in India most of them are vegetarians. So in this case we need to supplement with whey proteins, which is less in phosphorus and less in potassium, uh, so that they but although we give a protein target, we can ask them, is the because diabetes is the most common cause, we can give adequate calories of like 35 kilocalories per kg per day. So calorie intake we can give both in pre-dialysis as well as post-dialysis we can target. Yeah, this is the mainly optimize the protein
Yeah.
in all the population, including chronic
Yeah.
disease patients.
Yeah. Dr. Rihan, would you want to add upon the recent controversial guidelines from ICMR that don't use protein supplements, which kind of, you know, they are becoming very controversial because for those who wouldn't understand what's the need of it, it becomes more of a
Yeah,
controversy.
ICMR actually is trying to fix the damage that they've done over the years. They've come out saying that don't use protein supplements, don't use this, but they have not addressed the issue of protein malnutrition, period. So how are you going to get this protein malnutrition covered? So they can give us guidelines saying you need so many, 1 gram, 1.5, 2 grams, whatever it is. Like all the speakers have alluded to, it is not one size fits all. It's a clear customization and it goes from person to person. And then even the type of protein powder. I think what ICMR should do instead of telling the world how much protein and what protein is to first try and figure out is what is there in the market actually good protein. First, get down to that.
True.
Once they understand that it's good protein, then only the next step. Yeah, they don't have an idea as to the extent of protein malnourishment that's going across the country. So first, let them figure that out. As a crux body, they should be able to give us what is the need for this country and how do we actually combat this. If you shut protein supplements out, I'll give you a similar situation that happened in the US, and the price was paid for by one of the top cardiologists in. He was a chief of cardiology at the Cleveland Clinic, Eric Topol. I think he had almost $4 billion as NIH grant on him, and he made a blanket statement in the New York Times saying that dual antiplatelet therapy is not required for patients who've had stents after 6 months. So first 6 months you take 2 tablets, but after that aspirin is good enough. You don't need to take it. It is not true for everyone, right? The same like any of this. The whole of America stopped because he's a big name, and we saw people dropping dead like flies. Our ERs were filled with people with stent thrombosis. He lost his job. He lost everything in life because that's how the US is. They don't take it lightly. They first started figuring out why is this phenomenon of so many people being brought dead or brought in bad shape. Found out that half of them were referring to this New York Times editorial by him, which for whatever reason was misconstrued by people, and he paid a very heavy price for that.
I totally agree with you.
So
It's,
ICMR also needs to,
yes.
yeah. Go ahead. So ICMR, I think, needs to tell us first needs to rationalize what protein and how much all that is fine, but I think it needs to do a little bit of watchmanship on trying to figure out, are we getting the right protein quality? Is this protein doing damage to our patients, or is this protein safe for our people? That is more important than that.
It shouldn't be actually a blanket statement. I think it's doing more of a harm. Please, Dr.
Correct. I
Shukriya.
just want to jump into this. So what Dr. Rehan was saying about rationalizing the recommendation, right? Right now, if you look at it, it's like a 4-5 lines of it where they say part of it, and they talk about the damage that it can do to the renal system. And then when Dr. Dinesh was also saying that initially, right, you will really not know if they are in renal stage 1 or 2 or 3. And it's very silent, right? So the thing that ideally should be done is there should be probably a statement with a detailed verbiage that needs to be put. And Yes, there is. I mean, there is one part of it is yes, they are correct in terms of you do see a lot of young, kids taking protein supplements because they really want to build up, and you have gym trainers, who've actually, gone through a probably overnight nutrition workshop, and then they call themselves an expert, and then they would probably say 100 grams of protein, 120 grams of protein. I've had kids who have not told the parents that they're taking nutrition, like protein powders, but it's hid in their, friend's room, a friend's house, and they are actually taking it. The second, so I think a verbiage on who is allowed to take what should be probably given, and probably direct them to the nutritionist, saying that protein supplements needs to be under the discretion of a nutritionist. That is something which is, I think, very important. Second thing, Dr. Rehan actually touched upon something that I had experienced about 10 years back, and when we were conducting like a survey for one of these, it was an FMCG company only on all the protein requirements. And we had actually tested it in the lab. And one of the, I will not really want to mention it because I am no food farmer. And what we realized was what was on the on pack claim, right? It was not even a quarter of it. So I think there are now, I think there was some article couple of weeks back where they are saying that even are we doing the right tests for, like the protein testing, right? And it's correct. So,
I think ICMR should first rein in who writes these proteins. That's the first step. Don't tell the world that you have to have so much of protein and it'll hit your kidneys. We understand it because we are domain experts. We understand from where we come. But the guys who are writing it, left, right, and center, are guys who don't even know the spelling of the word protein. Right? These are all these gym trainers who I was just telling Doc. I have a colleague of mine, a dentist, 42-year-old fit guy, doing well, no logical reason for anything. His gym trainer convinced him to take growth hormone analogs, saying you have reached this point. From here on, I think now you need to go to the next step of muscle building. Take it. I shocked him out of VT 3 times this Sunday. Anaphylactic shock came in, and it took us 3 hours to recover a 42-year-old healthy guy. Luckily, he's come out of it, no neural damage, nothing. It's just luck. And all it took was this one. But that's the power of conviction also. They're able to convince their clients that you need to take all this.
I would like to add on to this. Basically, when it comes to this protein powders and gym goers, I mean, it's kind of now gone beyond the hands of a nutritionist because you know how the fad is basically, yeah, and then the lethal combination there is that they tend to get into dehydration. Yeah, and then they are taking high proteins, which is probably way beyond what is actually required because they'll also be eating half kg chicken and 12 eggs, and then they will be also taking the protein supplement, and then they go into this dehydration state when that is when they land up in hospitals with AKI. So probably as all of us are, I think what one thing we all of us should agree on is these conditions have to be specified when the ICMR says that, protein powders are bad, don't take, they should probably come down with, the explanation. Yeah, yes, that has to be said. And one more thing that I would want to draw attention to is basically when I started my practice as a nutritionist, even in India, when people said I eat non-veg, it would mean that Sunday they are eating 1 meal non-veg or 2 meals non-veg. But now over a period of years, when we do a frequent food, food recall, diet recall, we see that most of the youngsters do eat non-veg every day. If it's not cooked at home, they order. The Swiggies and Zomatos are there. So that is also something that we have to take into consideration. So probably here what it boils down to is you have to assess every case properly and customize it.
Thanks for that. There's just one last question to Dr. Dinesh, which is pending. Do patients come and speak to you that we are finding it a challenge to meet up the protein suggestion or prescription by the dietitian, caregivers, or the patient? Do they come, or your medical view on difficulty in meeting up the protein requirements?
Yeah, for the first thing, what any patient with CKD they ask is what diet will reverse the kidney problem. So that is a common question they ask. So we have to explain that this is a CKD and it cannot be reversed with any diet. That is the first thing. So, and yeah, depending on the stage and the nutrition of the patient, then we have to ask them to take this much diet. But usually we refer to a dietitian so that they take care of protein intake, uh, what are the diet they can prescribe to the patient.
Thank you. So there's no conflict of interest. That's good. So we do have questions online also, ma'am. Yeah. Okay. We'll try to quickly ask few questions. I'll not ask repetitive ones. So this is asking what can be the few pointers to diet to share with when patient is detected with renal cancer having IBS issue with weight loss. What are the simple instructions to give? Any supplement recommendations? You want me to repeat?
I think it requires multiple, Dr.
Yes.
Dinesh.
Basically, yes, I'll pass on the mic. Basically, this is a very specific case. I'm sure the person who's asked this question probably has somebody whom she or he has to tackle in this scenario. So it will probably be, it has to be dealt with week to week assessments. So she mentioned renal cancer. So probably somewhere down the line there might be renal parameters going haywire. At the same time, there is malnutrition. So all we could do is but one thing is for sure I can say that when you choose a supplement to replenish the protein and calorie requirement of this patient, choose something which is a little low on potassium and phosphorus, because then you can't keep, especially in an Indian scenario, you can't keep changing supplements every day. So if you start, and then it's always easy to give potassium and sodium on top, but then if you have to change the supplement, it becomes difficult. So choose a supplement which will give good amount of calorie protein but less on electrolytes.
Justified.
Can you repeat the question again, please?
Sir, what is the nutritional, ideal nutritional?
So what can be the few pointers to diet to share with when patient is detected with renal cancer having IBS issue with weight loss? So they say IBS, renal
So-
cancer and weight loss.
Okay. So so it's so the, so there are multiple issues here. So patient has got IBS, patient has got renal failure. We don't patient got renal cancer. We don't know the renal function. So first we have to see the patients, how is the patient nutrition. Patient is already malnourished, then I think the treatment line will be different. If the patient is not malnourished and there's a renal failure, again same, we have to follow the guidelines, and we give the protein if there's a renal failure around 0.5 to 0.6 to 0.8. Then we follow up with the blood test. So blood tests are very important. Every month they have to do a blood test and follow up. And pre-probiotics are very important when there's a renal failure, and that definitely helps in IBS. So when there is IBS, I think we also refer to a gastroenterologist.
So just to add on probably, so we'll obviously see what the patient is tolerant to. With an IBS, they have to have a diary of their own, see what they are tolerant to, and we can always pick up what is high in energy protein and prescribe the diet. So I think the questions from the audience.
This is to Shri Priya and maybe all others. I was just thinking, because you were talking about malnutrition. So could malnutrition be one of the risk factors for cancer?
So,
It could also be one nutrient malnutrition. It will not be like protein is a deficient thing in India. So it could also be that, right? Yeah.
So I would say that this is like a very challenging question. I think there is no clear data on it, though there is theoretical studies saying that malnutrition can result in cancers. But if you look at like the etiology of like say adult cancers, it would probably be mostly lifestyle related. And if you see mostly the categorization is on, the diet part of it, which is like sometimes it's obesity or things like that. The one link that I can think about where malnutrition can, and where there are studies that are related that it could cause cancers, is maternal health, during maternal health. So, sorry, maternal health, and then like, post delivery, like, how it's usually in childhood leukemia, certain type of cancers in children. And if you look at the causation of childhood cancers, a lot of them is genetic in origin, or it could be even certain kinds of like Epstein-Barr viruses and things like that. Okay, and there are been studies that have shown that when a maternal nutrition is actually impacted, then the child that is born later or during a pregnancy, when this deprivation has happened, it can lead to certain types of cancers. I hope I answered your question.
Yeah, thank you. What about pediatric? I mean, because we have quite a poverty in India, and there are a lot of malnourished children.
That's what I said. So maternal health,
same.
yeah, maternal health can have an impact on the risk of a child that's born with cancers. Want to add something?
I would just like to add, basically the some of the factors that are linked to carcinoma is the inflammation and the, the suppression, immune, low immune, compromised immune function. So, and then any nutrient or nutrients deficiencies can cause inflammation and, suppression of immune function. So you could take the link in that direction. I'm not sure if we have any studies published in this, in this path. But then this is for general, I mean, for everyone of us to think that when there is immune suppression and inflammation, which could be a trigger factor, because now we know that most of the time, there are so many triggers, environmental and nutritional triggers for cancer. So probably this could be explored.
So, ma'am, all of us have oncogenes. Everyone in this room, we all have oncogenes. Some of us have cancer, some of us don't have cancer. So the trigger factors are different for every type of cancer. So these trigger factors can be anything. If you are malnourished, you have chronic infections, chronic illnesses, they can be a trigger factor. Or you are more sensitive to certain environmental toxins compared to... I also get asbestos, you also get asbestos, but I get lung cancer and you need not get lung cancer. There is no hard and fast rule. So I think on that grounds, yes, if you have malnutrition, or even specific, say, protein malnutrition, it predisposes you to a low immune status. That can result in chronic inflammation, chronic diseases. That can further trigger off. And the same applies to if maternal nutrition is bad, then it triggers childhood cancers because the fetus is deprived of its nutrition. So on that count. But all of us are cancer prone. We all have a set quota of oncogenes in our body.
I think this is a question, Dr. Rehan, again. As it is, vegetarians and women don't eat too much protein. If you calculate in a normal diet, we get around 0.6 to 0.8 grams. I think we don't get more than that. This is for a person who's healthy and doing a normal life. Now, when they increase it to 1, 1.2 or 2, whatever in the illness, when as it is, the appetite is totally there, how do we plan to give this to the patient?
I think that's where I always felt that vegetarians will not get all good protein, and it's difficult. They will have to go to supplements in order to make good the entire protein requirement.
No, they have no
and
appetite.
That's the only way.
Yeah, as it is, they have no appetite. So even if you give them a supplement, it's difficult to force feed the patients.
But no other go, no, ma'am. In the sense that if you don't take it, then you're going to be, over a period of time, you'll become malnourished, protein malnourished.
So I noticed that most of the products that have come out are whey-based. So people with milk allergy or lactose intolerance, will they be able to take this Wello'Tree protein supplements?
I would say with lactose intolerance, maybe not. But this has only 50-50. It is 6 grams of whey and 6 grams of plant protein. We try to mix. Pure plant protein is very, very hard to take.
Right.
It's horrible to taste.
Right.
So much as what people say, it's very difficult. So even this, my fight in the hospital for the last year has been with patients, my own patients complaining is that it's a little bit bitter compared to your other FMCG products. It's bitter because I have a little bit of plant protein. I have HMB, which is very bitter. I'm trying to mask the taste of HMB. Haldi or curcumin has its own taste. It's very strong flavoring agent. I'm trying to mask that. I refuse to take lycopene out because it's a good thing to have inside. That's also bitter. There's so many things that causing bitterness. So I tell them that, it's like mine is dark chocolate and that's milk chocolate. So you have to figure out a little bit. But the dark chocolate is good for health and the milk chocolate is bad for health.
Right.
So that's the only explanation that I can give. But I think there's no other way to
Right.
get your protein content in. You will have to take what needs to be
Yeah,
taken.
so it's more a statement than a question, I guess.
Yeah, absolutely.
Thank you, doctor.
The very relevant analog that you used. Any other question from audience? Anything which bugs your mind, want to ask?
If you want to increase the appetite, there are appetite stimulators, especially in CKD patients. See, initially we start with PPIs and antiemetics. If they are not responding, then there are drugs like megestrol, where it's also used in malignancy as well in CKD, so that the appetite starts improving. So they feel better. So I start 40 milligrams twice a day and then increase to 160 milligrams.
Good afternoon, ma'am. My question for Sunita madam. Ma'am, this is one simple patient's opinion reflections. Most of the times we dietitians also will become a mum to answer for those when they're questioning back. Ma'am, most of the time they ask for like a potassium reduction in their diet. We advise them leaching of the foods, boil sometime and remove those. They are questioning back again the practicality of that. Is it really work? Really, we are ready to take a risk. We don't want to do waste attempts because we are nowadays all are work burdens and everything, their family things. How it works really? I want.
I got your point. Basically, there are two ways here you can do, and there are also two theories amongst nutritionists themselves. We are divided with two theories. Let me tell you both theories. One is that there is one section of the dietitians, the renal nutritionists, who believe that why don't we leach why don't we advise leaching so that they can eat everything and everything. So you don't have to worry. But then there are another section who believe that when you are at least giving a part of the vegetables per se, or vegetables or whatever it is, in the whole form, without leaching, then at least let them get the nutrients completely without losing the water-soluble vitamins, the taste especially, and only, maybe manage that by avoiding a few foods that are really high in potassium. So, one practical way of approaching your patient's, problem is try to avoid those potassium-rich foods that are very high, maybe above 350 mg per 100 grams, and then plan a diet with the low potassium foods without leaching, and see where they stand. Their potassium will not go very high with that. So of late, we don't really recommend leaching to everybody unless they are really going high on potassium, even after restricting certain foods.
So I second her thought. Basically, try to avoid just very high potassium foods rather than restricting everything, because when you leach, you lose many things else.
Yeah.
Rather.
And the taste becomes so insipid that they don't feel like eating. And then, as you said, the work burden.
Any more questions, or are we done? I think it's time. Everybody wants to move before it starts raining, probably. So thank you so much to all the panelists. Especially Dr. Dinesh flew back from Europe yesterday, and thanks to you so much to take out time and come with us. All of you have taken your time. Time and energy for all of us, and it's been a really impactful, I think it has influenced, definitely there are many key points for all of us to take back home. Thank you so much. And with that formal vote of thanks also.
On behalf of Wello'Tree, I'd like to thank all of you for being here. It's a pleasure and an honor to have you all, and it's a learning for all of us. Because the last time I was here was with the ASNFS, and it was a new learning again. And now another brand new learning. So every day it's something new for me. And I'm hoping that this learning will translate into making the product better and better and trying to refine what we can do. Thank you so much for being here.
So, and also from my side, from IAPN Bangalore chapter, we thank Wello'Tree Solution for giving us a chance for this nice conference, and to Sheila ma'am for the venue, and Mr. Siddhan from IT team for helping us with all the IT settings. To all the speakers, thank you so much. And I would want, we would call each person, you can please go back to the dais. And first, Dr. Rehan can stay back. I would want you to felicitate Dr. Dinesh. Dr. Dinesh. Thank you, Dr. Dinesh. So, oh, still, careful. Can I request Sheila ma'am, please to come, ma'am. Can you please felicitate Dr. Rehan? Ma'am was escaping, we just held her. Can I request Vijay ma'am? I'm pleased to come over to felicitate Dr. Shripriya.
Can you turn off the projector?
Yeah. Yeah. Excuse me, Sheila ma'am.
Ma'am, we want a group
Photo, ma'am.
of you.
One photo. We are done, just a photo. Shripriya. Shripriya. I request Meera ma'am to felicitate Sunita. Ma'am, Meera ma'am. Thank you so much, ma'am. And thanks to the lovely audience for being here and for your time. Thank you so much.
We would like everybody to just come forward. We take a quick group photo, please. Ladies, Miss Sheila, please come here. Thanks so much.
Yeah,
We have one more felicitation left.